Welcome, everyone.
Tell me just how long you're ready.
Check again. We're gonna mute that microphone.
Roll call at 102. Excuse me, call to order at 102. Roll call. President Fonsby,
Present.
Vice President Canning,
Present.
Commissioner Breslin. Supervisor Chan is excused. Merit Commissioner Howe will be joining us shortly. Commissioner Scott will be joining at 1:30, and Commissioner Zavansky. President Fonsby, we have quorum.
Great, thank you very much. Before I call the next agenda. We think we would. So again, I wanted to welcome you to this really important meeting. Many of you are aware that all over 3 years ago, the Health Service Board met with HSS and many of you to come up with a strategic plan for 2020 through 2022. That plan, in my estimate, was quite successful. It helped guide our thinking, our response to innovation requests and ideas, and particularly around several of the important projects that were accomplished by HSS and the board, in conjunction with the board, in these last 3 years, including the RFP for non-Medicare health plans, the RFI for Medicare, as well as many discussions with vendors, our members, and each other about what we're about and how we judge ourselves and continue to monitor ourselves. Today, my goal is to see that we come up with, again, an equally successful, if not more successful plan for 2023 through 2025. And the responsibility is probably even more difficult now because we realize some of the challenges that we faced in the last 3 years and the uncertainties that we face in the future. So with that, I welcome you for an afternoon that will be productive and I suspect will be hard work for each of us. On a personal note, I want to make a couple of comments about the COVID epidemic. I appreciate all of you being here. As I look around the room, I see that 95% of you are masked. This is in the face of the fact that the city has decided that masks are optional in this setting. That is based on, I think, a couple of assumptions. One is that all of you have been vaccinated and all of us have been vaccinated. And it's also based on the assumption of the principles of liberalism, that we take care of ourselves, and we take care of each other. That means we take care of everyone in this room, we take care of everyone in this building, we take care of everyone in the city, and the state, and the country. And we have a responsibility in that regard. The optional mask policy, to me, as an infectious disease doctor, is at this point in this room for this meeting is a suggestion we are being experimented upon. We are being experimented upon because this policy is new. It was instituted this week, and it puts us all in a new situation, in a building where the ventilation is up to code, so that if we fall asleep during the next 4 hours, it's not because we're tired in the afternoon or because of CO2 narcosis. The ventilation is quite adequate and adjusted to make sure that our CO2 levels in this room are safe and maintained. They're not designed to reduce the risk of infection. And the staff attempted to get permission to use portable air purifiers And we're told that we cannot do that because the electrical system of the building won't support ancillary equipment. So there is no additional air purifiers in this room. In the interim, since this plan was being devised, I actually became sort of a semi-expert on portable air filters. So if you had any questions about the literature, let me know. Be happy to answer them another time. I had attempted to try to segregate people in the room, those people being masked in one section, those being unmasked in another section. I don't think that's necessary. But my goal is to try to remind each of us that we do have this responsibility. There's many unknowns yet about COVID. We know that hospitalizations are down. We know that deaths are down. We know that cases are rising. They're rising in the city, they're rising in the state, they're rising in the country. And the ramifications of that, although not necessarily deaths and hospitalizations, are unknown. We don't know what the effects of long COVID will be on those of us who acquire COVID, having been boosted or reboosted or vaccinated. There will be disruptions to system, social planning, et cetera. And there's certainly disruption to the healthcare systems. And I noticed that the healthcare medical centers in the city are maintaining a mask mandate in their facilities to try to keep each other safe, the patients safe, their staff safe, and minimize disruption to services and healthcare. On a personal level, I'm scheduled for surgery on May 26th. And I was told last week that I have to be COVID-free for 7 weeks prior to my surgery. I've got 4 more weeks to go to remain COVID-free, to anticipate surgery that I've been waiting for a year. And so I have a personal reason. Others of you probably have personal reasons. There's never a good time to catch COVID, but maybe you have additional reasons not to catch it. And I ask that we all respect each other in those regards. So with that, again, my goal is to encourage all of you to wear a mask and not to fatigue from wearing a mask during the course of this afternoon. They are uncomfortable, I know that for a fact. And probably an innovative approach to the president's message at this point, at the beginning of this meeting, I want to carry you through a visualization as president of the Health Service Board, as an individual, not as president of the Health Service Board, and not speaking obviously for the city and county of San Francisco. The visualization is for you, each other, to think that you're standing next to me. If you stand within 6 feet and 5 inches, which is my height, and my defibrillator doesn't work and I drop dead, I'm hoping that you're far enough away that I don't knock you over when I die. And so please, if you want to be safe, stand 6 feet 5 inches away from me, which is 2 meters. For myself, I'm going to visualize it in a different way. And those of you who try to approach me within 6 feet of my space, I'm not going to worry about you falling over and dropping dead and crushing me. I'm going to visualize you opening up the front of your clothes and peeing on me. That is what you are doing. If you are harboring COVID, don't know it, and are within my space and put me at risk. So that's the visualization for yourselves. I'm letting you in what my visualization is. And with that, I will go ahead and open up for the next agenda item.
Thank you, President. Thank you, President
Thank you.
Follansbee. Thank you, President Follansbee. Agenda item number 3 is the Health Service System Strategic Planning. This is a discussion and will be led for the rest of the day by Executive Director Abby Ant.
Good afternoon, everyone. Thank you for being here today. We have been hard at work developing the plan. Those of you that are planners know that cycle that we're in. And we have a great team at HSS that has supported me and the work that we'll bring the meeting together today, as well as the plan in its entirety by the early fall of this year. And so we are highlighting a number of things today, and I'll go through them, but this is not the end of board and public involvement in our strategic planning process. So I just want to lay that out. Today, we really wanted to just bring together some, let me get the slides caught up here. The presentation aims today are to bring together this broad set of thinkers and perspectives to help shape future programs to best meet the needs of the diverse populations that we serve. We want to really elevate the core focus areas, and these are terms that were new to us in 2018 when we developed the strategic plan, and I think we have a much deeper understanding and a ways to go on learning about population health, mental health, primary care. The definition there has changed over time. The health equity issues have become very forward-facing, and well-being at work has become more and more integrated into everything that we do. So we want to identify these important changes in the circumstances around HSS so that we can keep our strategy fresh and keep it relevant, and the team at HSS can continue its support of our membership with a clear vision on the future. We have, as I mentioned, have the strategic planning process has already begun, and we've already checked off a few key points where we kicked off the planning process with an expanded leadership group within HSS, and worked with Aon on some exercises to really look at, our sort of internal philosophy and guardrails on how we want to approach our strategic plan. And then today, at the last board meeting on April 14th, we highlighted for the board and our leadership team the many documents that we have that really describe current state as far as the health and well-being of our membership, the and the programs that we have available, and how tools that look at the portfolio of work projects that staff has underway. Because as we all know, when you plan to make change, you really have to have the resources to do that. So it's important to kind of have a clear understanding of sort of what the current state is, so as we prepare for the future, we can make those adjustments. So that brings us to today, where we are, as I outlined, going to be able to sit back and listen to some people that we that many of you have not met yet. Our first speakers today are Dr. Derek Von Brunt and Shamar Clemens from the Credible Mind organization. Some of you, I hope many of you, are familiar with Credible Mind because they are a vendor of HSS, and I'm going to let them tell us about it in detail, but it's been a pleasure I've worked with Derek in my former life as a community health administrator for nonprofit hospitals, and we worked on the community health needs assessments. Derek had developed a tool for making that a very public document to engage community in solution. And so we reconnected when he had developed this new product that the team thought was really worthwhile. And so I think it's helpful. We all know that mental health is very important these days. There's just no doubt about it. And I think we're all learning how to think differently about mental health, about our own emotional well-being, and then as a health service system of how we meet the needs of our membership. So without further ado, I think, can we turn the slides off or switch to Derek's slides?
Mhm.
Okay. Hello. Okay. Good to see you. Yeah, good to see you. We're going to grab this chair. All right.
Well, usually I'm not asked to put people to sleep, but I'll do my best. I'm Derek. I teach at UC Berkeley in the School of Public Health, clinical appointment, and one of the co-founders of Credible Mind, and working with Shamar, and we're very happy to be with you. We're not going to talk much about Credible Mind. I will happy to talk a little bit about that. What I want to talk about is that we're nationally in a mental health crisis. And you folks here on this board have tough shoes to fill because we typically have about the same or fewer resources. We have a plethora of mental health problems that span everything from traditional mental health categories to sort of social determinants of health kinds of factors and contributors. And there are literally, at last count on our end, over 20,000 individual solutions out there saying that they can help you address mental health. And so there's this paralysis that kind of sets in. And frankly, the science is just not that good on most of this stuff. Leadership is extremely important right now. You need like a North Star. So what we're going to talk about, I'll spend just a couple of minutes on a few numbers so we're all on the same page around mental health. But what I think I hopefully can offer that's useful are one or two models around what I call population-based mental health. Let's sort of get this out of the way right now. We all know that in the physical health realm, we've moved from a largely reactive system of care to a population health system of care, which involves more prevention and early intervention, right, over the last 30, 40 years. And as a result, we've reduced, cardiovascular mortality rates related to cardiovascular problems by 60, 70%. But in mental health, we haven't really done that. We're still largely a reactive system of care. And yet we have evidence to show that early intervention and prevention works. So how are we incorporating this in the work that we do? So that's what we're going to talk a little bit about, and how can we do that in a practical way. I know it's a little silly, but it's not that silly. We've come a long way, but mental health is something that started off pretty out there. And, today we have what we call evidence-based approaches, medications that work for some people for certain conditions, therapies that work like CBT, but it's not a panacea. It's you got to have the right diagnosis. You've got to have a therapist that uses evidence-based approaches. You've got to have the right relationship with the individual. This is assuming they had access and got there to begin with. And then you got to see through the whole program. So there are, I'm not anti-therapy or anything like that. My wife is a therapist. What I'm trying to say is that's not the solution to our mental health problems. So we need to think a little bit out of the box here on what to do. So let's go through just a couple numbers. So pre-COVID, mental health has been a very big issue in our communities. Roughly 20% of people in just sort of general society having diagnosable mental health conditions any given year, half of the population over their lifetimes. Okay, so big numbers, huge costs, and we have a massive behavioral health therapy shortage, and it's getting worse. Not only is it just numbers of bodies, but it doesn't reflect the people that we're serving. So particularly around people of color, as an example, you have a disproportionately small percentage of therapists and professionals, which can make a difference for individuals that are engaging with that kind of therapy. COVID has made this a lot worse. So it wasn't good, and it got a lot worse. Just as an example, anxiety and depression rates are somewhere between triple and quadruple what they were 3 years ago. And here's the last piece. Sorry for all the bad news, but then we'll get on to some good stuff. This is sobering. And what we've learned from SARS, MERS, 9/11, and other kinds of disasters, if you will, like the pandemic, is that these increased rates, it's like we kicked a hornet's nest. And these higher rates are going to be with us for 3, 5, maybe 7 years. They don't just go away. So think about someone who was very lonely during the pandemic. Maybe they start drinking more. Suddenly they're healthier. Maybe the fear around COVID has gone down, but they still have their drinking habit. It doesn't just go away. That's just one example of many that we could choose. So you folks, have a large population that you serve that has an increasingly large mental health challenge, and it's not going away real quick. Let's look at burnout. So we all hear Doctors have really high burnout rates. They do. I work with a few, and some of the folks on our own team that also practice clinically, ER docs, et cetera, are in fact, struggling and working hard to find a balance in their lives. But I found this rather shocking. You look at so this is a survey that Medscape had of 13,000 docs, found just under half of the docs were reporting serious symptoms of burnout. Nurses, 64% higher. Police, just under 60% higher. Fire departments aren't listed on this, but I've seen very high numbers around that. Basically, first responders, teachers. You have many. These are all your folks. These are largely the kind of folks that you folks serve, and they have very high rates. So it's not just doctors and clinical teams. It's not just the frontline folks. It's a large percentage of the people. The other thing that you serve, the other thing is to keep in mind that there are vulnerable populations that are disproportionately hit. And I know we see this a lot, but it's just too easy to think in terms of like, oh, teachers this, police that. I mean, we've got anyone who's in a frontline working capacity has extremely high rates, close to 2/3 of quote diagnosable stress. People of color right now not right now, this was about 9 months ago, about 1/3 have diagnosable mental health conditions. This is again up from what we've had before. LGBTQ, 2.5 times more likely than sort of general heterosexual populations, if you will, to experience depression, anxiety, and substance misuse. Youth are disproportionately affected. And I don't know that this affects you, but it was sort of involved in the same stuff around asylum seekers and people coming in from distressed countries. So I had an aha moment a couple of years back as I was kind of looking into all of this, because pre-COVID, I was very interested in mental health, some issues personally in my family. My wife's a therapist. I've been, working at Berkeley and in the world of technology and health for a long time. So I was like, what could we do around mental health? And I'll tell you briefly about that story. But jumping to the bottom line, the aha moment was this. It appears, I wouldn't hang your hat on this stat too strongly, but we've seen it in a few different places. Roughly 3 out of 4 people that have mental distress work on that on their own, not just because of access or financial ability. People are interested in working on that, at least initially, alone. It could be a cultural issue. It might be that they don't feel it's that big an issue and they want to see if they can fix it first. I know this certainly fits me. I've got certain issues that I've faced, and I definitely want to see if I can take care of it first. So we have this giant line, if you will, to see therapists and clinical teams, too many, shortage of professionals, huge costs, and roughly 3/4 of them could step out of that line, figuratively speaking, if we could provide them with evidence-based self-care. And then, of course, reintegrate them into professional services as needed. Maybe the self-care won't work. That's fine. So building on that, we sort of put together a system that you folks use, and we'll talk a little bit about some of the numbers in a minute. I mentioned this briefly earlier, but you folks have a particularly challenging time right now because there's this plethora of mental health apps, podcasts, videos, online programs, various services, books, thought leaders, et cetera, that are coming to you saying, hey, we can help solve this problem. And there's no panacea out there. There's no sort of one size fits all. And it's very hard to know where to send members, into all of this. So let's move from the problem to how to think about this. We did some work several years ago, pulled some folks together from Berkeley, of course, but Harvard and Stanford and industry and health departments and large employers and individuals that had mental health issues. We did what academics do, and we spent about 18 months just talking to people and doing research. We found a couple interesting things. So one is the numbers we found of what people were worried about, stress, anxiety, et cetera. Again, this is pre-COVID. They were all kind of, what we were seeing in the literature. No big surprise there. But there are 2 surprises. One is, lower right, that about half the population that we surveyed said they either had a diagnosable mental health condition or thought they had one. That's larger than any of the numbers I've shared so far. And the second and I find very positive and interesting, is over 80% of people said they had a strong interest in spiritual growth. Organized religion and the practice is going down in the United States, but the interest in spiritual growth is quite high. People are interested in resilience. They're interested in flourishing. So we interviewed tons of people, and we basically said, if you've got a population that you serve, like you folks do, what is it that they're looking for? They want a positive framework for the work that they're doing. They don't want to just say, are you depressed? Do this. They want a positive framework for everyone. I'll show you two in just a moment. They want to cover all the topics to help folks. They want things to be evidence-based. They want it to be free and connect people to the service level that they need. So, framework one, Corey Keyes, Emory University. Most people think of mental health this way. Got a mental health issue? Don't have a mental health issue. You're somewhere on the line and there's a label for that. That's how a lot of people approach mental health. That's how they think about it. They don't really have the training otherwise. And I'll just say the bottom line is most people do not identify with being a point on that line. That does not capture who they are, their struggles, or their hopes. So Corey Keyes said, we need another dimension on here. We'll call it flourishing and languishing. And the idea is people can be on different places on this scale, right? I know people that don't have a mental health issue and they are definitely languishing. My brother, no, I'm joking. And then there are people that have mental health issues and they're flourishing. And so the idea is that we're all somewhere here and we all are interested in moving up and to the right. So everything from the topics to the culture that we create, it's a culture about helping people flourish in their lives. And along that way, you mitigate mental health issues at the same time. We don't want to think in terms of the box of just the sort of diagnosable conditions. And that helps address the issues of stigma related to that as well. This is a very simple model. It's just to sort of emphasize, I'm trying to give you some visuals because as you know, I was asked not to put you to sleep, but to be a little provocative. And as you think about the choices in front of you and how you allocate funds and groups that you work with, keep in mind that a very large number of the people that you're working with, they're going to do something on their own. They may go off to Google, talk to friends, do whatever. But if we can make this evidence-based, and you folks are doing this now. So you work with us, you have this Credible Mind system. About 5% of your membership is engaging with the system on an every 12-month basis. That's about average. We've got folks that have more and folks that have less. It's very hard to get people to engage. And we're getting statistics around whether it's helping them, which is around 70 to 80% report. These are of people that, you know, reply to surveys, that they would recommend it to someone is around 80 to 90%. But the most interesting statistic that we got was, and this is not just your population, people using the system that responded to a general survey, about half said that it was that it helped them make a positive behavior change. I just want to pause on this for a moment. I studied behavior change in grad school, right? First of all, there are no good theories for behavior change that explains more than about 20% of the variation of behavior, period, for anything, smoking, weight loss, whatever. So to have half of a user base say that it's helping them make a positive behavior change. Now, these are, again, self-selected group, just people that responded to a survey. But, you know, you had people that were complaining as well as being positive. Stunning and very encouraging. So you folks are doing this now, and it's working to some degree now. But I think the framework's good as you think, because this side, the right side of the equation, really costs a whole lot more money. Right? This is more professional services. So there's a lot you can do that costs less. One question I often get is, does early intervention really work? Yes, really does. We've done a lot of research. We have hundreds and hundreds, thousands of studies, hundreds of approaches and what conditions they help with. So that's a whole knowledge base that we've put together. You would think you could just go look it up at SAMI or something. You can't. We had to sort of just dig it out and pull it together. And again, it's embedded in everything that you folks are doing now. So, you know, exercise does help reduce depression. You know, meditation does help reduce blood pressure, blah, blah, blah. So the idea is, and this is just a random set, right? There's hundreds, thousands of these, and they're all embedded in things that you're doing with your membership right now. Okay, so let's shift to, as you sit here today, what are some things that are helpful to think about what might you do. So I literally, we have a story to tell you and 2 slides I just took, what are we hearing from other groups around the country? I'll loosely call it best practices. And what are some things that you might do? Most of what you're already doing to some degree now, but I thought I'd just sort of put it on the list for you. So we're going to do that in 1 minute. But let me ask Shamar to come up. And, you know, you folks are a public agency here. We've got a project going with the state of California. It relates to what you're doing. And I thought, Shamar, you could tell them a little bit about it.
Sure, thank you. I'm Shamar. I'm master's level social worker who's a research and data coordinator at Credible Mind, and I'm working with Derek on a project now that's funded by the state of California. We're piloting this year in 1 county and hoping to expand to others. But the project is a self-use online mental health screening and referral tool. So whenever I talk about this, I feel like I have to go through that 2 or 3 times for people to digest it. But basically what I'll do is break it down and describe how it relates to the things that Derek was speaking to. So first, it's a self-use tool. People who, again, are seeking services for mental health are people who thought they probably would never have to do that historically or previously. People who may not be willing to go into a clinic or talk to a clinician face to face are now recognizing that they are having things that are impacting the way that they live, and they want to seek help. So having a self-use tool enables people and empowers people to be able to take those first steps without having to go through maybe the traditional model, and reducing those barriers, improving and increasing autonomy, and again, empowering people to make that choice for themselves. Self-use tool, online tool. So again, in reducing barriers, we're talking about, if you think about how things have been going during the pandemic now, lots of things are moving virtually, things that probably should have been virtual before, to allow people to have that accessibility. So we're talking about reducing transportation barriers, mobility and disability issues that people may be facing. Those barriers are reduced. There's also a privacy aspect, again, for people to be able to use this on their own without feeling issues around stigma or discretion. With online use, people can use it however they access the internet. So whether that be from a personal device or even something that could be loaded on a library desktop or a school's webpage, so that people can access it however they access the internet. So again, self-use, online, mental health, self-explanatory, but again, it's kind of the co-current pandemic that's happening with COVID, but also all the other devastating things that are happening in the world. Next step is a screening tool. So this tool is using already validated screeners, looking at some of the most important conditions, helping educate people on what conditions they may be at highest risk for, but also more generally, whether they are flourishing or languishing. Someone may have lots of things that might qualify them for an anxiety diagnosis, a depression diagnosis, but may not reach the criteria for a diagnosis. But looking at that comprehensive picture and seeing how the different things that they're experiencing are impacting their life. So not only is it connecting people to the tools that they need, but also giving them the vocabulary, giving them the basis for which to advocate for themselves if they do decide to go and seek clinical help. And then the last step is a referral tool. So a lot of times these things happen separately from one another, especially if you are using it as a self-assessment tool instead of seeing a clinician. But this is not only assessing people, but also connecting people to resources. So that can look like connecting them to very easy, accessible information on how to seek out their county behavioral health services, but also other local services, things like peer resources or NAMI or local AA meetings, things that may not have the same eligibility barriers as some of the county mental health services, and things that might be more culturally relevant to a person as they're choosing to embark on this journey. They can also be connected to online self-help resources, as Derek mentioned. So people who may not be willing or feel safe, especially during this pandemic, around being able to seek help in person, are still able to be linked to resources that are really tailored to their assessment results. So again, this is a self-use online mental health screening and referral tool that we're working on. And just to kind of sum it up, I really think it ties into the public health systems model. And I think a really simplistic way of putting that is making the healthy choice the easiest choice. So really shaping these systems and shaping the programs that you're creating to make it an easy choice, an empowering choice, and an autonomous choice for people to make in their pursuit of their mental wellness.
So that's a really exciting project. And again, you folks do some of that now. As I said at the beginning, much of this, we're already starting to do some of this with you, but this tool is going to be more comprehensive across many, many different conditions in sort of one place. And, you know, it's all about keeping it easy, right? Making it accessible. Engagement is really tough. Stigma is really tough. So when you can get people to come into these and think about just the cost efficiency of the triage being done by yourself. I'm low, medium, or high risk. I want services, or I want to just go do some self-help. It's enormous what the financial implications of that are, as well as reduction of pain and suffering and convenience and all of the rest. So that is one bullet on this where it says sort of assessments. Okay, I'm a fan of one-pagers, so I put just about everything that I'm seeing people do around the country that seems to be working on one page. I won't go through this in too much detail. I'll give you like 1 or 2 sentences on each one. The idea is it's a little checklist for you guys to think about, and I'm sure much of this you're doing. So number 1, both on the list and in importance, is leadership. Let me explain. I'll tell a short story. Down in Madera County, there was a behavioral health department that they knew, you know, a bunch of workers that were fairly stressed out. And so the head of the department said, listen, he told this to his whole department. I took a burnout assessment, found that I was moderately high, found some tools that were helpful to me. It's all private and confidential. This is a tool that we're making available to you. You should see how you're doing. Reach out for help if you can use it. And again, there are a lot of self-help tools here too. Destigmatified the topic by, as a leader, saying we are all hurting to some degree. Let's help each other and let's help ourselves. He sent an email out on Friday with the burnout assessment. By Tuesday, about 25% of his department had taken the assessment. They had never seen engagements above 5% for anything. So that blew them away right there. The second is they found that over 50% of people were at moderate to severe levels of burnout. Bad news, not good. Further, the assessment captured what was the driver of the burnout. Number 1, across the population, number 1 reason was job insecurity, stress around their jobs. There were no planned layoffs. Management was bewildered. It's like, we haven't said anything about layoffs. So they immediately got the word out to everybody through the management teams that there weren't going to be no planned layoffs. In 1 week, they sent out an assessment, got engagement, collected data, figured out the problem, and basically put together what I'll call a soft intervention in 1 week and started to assuage the intense level of burnout that department had. That's the kind of value of these assessments and the data that's collected and the insights that can occur. And you folks can do this across any department, all of these different topics. The tools are there now. It's really a leadership issue. Who's going to tell the story? Who's going to send it out? What are the teams that are promoting this so that people feel safe and comfortable engaging in this? The tools are there. Okay, leadership's number 1. Driving engagement. The only thing I want to add there is build trust. I think you folks have trust. As far as I know, you do. I just want to pound on it as hard as I can. I know organizations that lost trust. Once you lose it, it's gone. So when you say we're not using the information or we're not sharing the information, walk the walk and show them. There are 2 fundamental approaches when we talk about improving mental health for the population that you serve: organizational transformation, personal transformation. Organizational transformation, these are things like putting working groups together, allowing for flexible work hours, childcare, blah, blah, blah. You have Aon, a fantastic group that can help you typically with these kinds of things and best practice sharing. And again, you do many of those things. I've been speaking today more about affecting personal transformation within your own membership. I think a huge way to think about a lot of these services and information is no wrong door. If someone is suffering and they have to go find help, and they go here and that wasn't the right place, and they go here and they spent time and it wasn't the right place, they're already done. So you've got to make sure that wherever they go, it's all there and it's all intuitive. And there are tools these days. And again, you have a platform with us and with a lot of the work that you do. And I would just strongly reinforce that. It's very powerful. Keep it simple for people. Obviously, making sure everything's evidence-based. You guys are really good. You guys beat us up big time when we started working with you to make sure everything was evidence-based. I'm just letting you know that's good. Assessments to help people find out where they are, self-triage, and then engage in the right level of care, huge. There's something out of Canada called the stepped care model. It basically, think of it like layers of the onion. It's not, self-care, therapy, or medication. There are many more nuances then, right? There's kind of more self-care, peer support, coaching, therapy, medication. There are many different layers here. And you folks, again, with Aon are doing an awesome job. There are these narratives that you've created. I don't know if you're talking about that today or not, but they're really good. I think they're fantastic, where it's, here's an individual with this challenge, and here's how they're engaging with our system, and here's how they find what they're doing. I think that's fantastic because you will identify the holes and you will fix the no wrong door issue. And I think that's just splendid work. Cultural appropriateness and everything, and it really addressing social determinants of health. Let me pause on this one for a minute, because that sounds like sort of just noun speak. What does that mean? What I mean is that even though your members are employed, they still have the same issues as the general community. I'm not saying the numbers are exactly the same, but they're pretty darn close. People that have food insecurity, people that maybe just don't feel safe in the workplace through bullying or just not feeling heard or seen. These issues, financial security, these are issues that they are just as important to your members as they are in the community. And you can't fix it all, but you can help address these issues. And again, we already are working with you on some of this. I'm just saying I wouldn't shy away from that. Take these issues on, understand. So let me concretize this. Anxiety. You take something like a diagnosable condition, depression, anxiety, burnout, and you unpack it with what the triggers are. There are 17 known things that you can do to reduce anxiety. Some of them are more clinically oriented. Some of them have to do with feeling safe and things that you might call a little bit more social determinants of health. Take it all on. That doesn't mean you're out there in the community taking it on. I'm saying take on the topics and help empower your members around these topics. You guys are a big buyer. I wanted to take a moment about this. You folks have power. You're a customer. You're an important one. You're more sophisticated than most, and there's a fair amount of money flowing through. So when you folks were talking with us as a vendor, and you started asking and pushing for things, you pushed us. You've had us made commitments for certain things. An example was, we want these things to be available in Spanish with this amount of time. And you got it. So my suggestion is, as you identify things that maybe you can't do, maybe it should be the insurance company that you work with that does it, or some other partner. Externalize, take on what you can, but externalize. You don't have to do it all on your own. So whether it's cultural appropriateness, percentage of therapists that are available in a service that are of color or different cultures, languages that are made available, these are things that you can push. And I know, again, you do to some degree. I'm just saying, keep people's feet to the fire. You're the buyer. And you can help effect change, because they start hearing that from more and more people, and they make the necessary investments. Data should be integrated with everything today. The idea of having isolated systems is just, well, it's like a mini tragedy. So you want to make sure that everything from the insights from all the self-care activity to therapists that people are going to, all of this should be data-driven and evidence-based on how you're planning the next step, the next step, the next step. It's a continual process of improvement, for positive outcomes. And the last thing is just celebrate wins. This is hard work, and people forget you're doing great work. So take the wins that you have, maybe have, wellness task force. Maybe you do this. I don't know enough about your organization. I'm not an expert, that are working cross-departmentally for certain things. And they have stories, like I told you, the one about Madera County. Have stories, celebrate them. It's part of your culture. It helps destigmatize, helps people realize, oh, we're doing these things and they didn't misuse that information. It does so many positive things for you and your members, and people forget to take time to do that. Okay, I think that was really the main thing. These are super important topics. These are not things you do. These are things that fall out of, when you do those other things, you begin to create a workplace of psychological safety. You begin to really address health equity. You don't just open up these one day and say, let's address health equity. You have to sort of do these things. And then you start addressing health equity and getting engagement, personalizing the experience for each of your members so that you're meeting them where they are and within their sort of belief system. There's ROI all over the place for some of these things, but one of them is just retaining talent. If you create a safe working environment and people feel that they're heard in their work environment, there's about triple retention rates. Okay, so that's a big workforce shortage is a real issue, and turnover is a big driver. So especially these days. So these things have a very positive effect and obviously capture the data. So I thought we could just open this up into any Q&A. I'm not that familiar with your timetable, so I hope that was about right, Abby. I just thought we could discuss this as a group now, but I was more leaving this for you kind of as you go forward. Are you building a culture of caring? How would people answer that question? Because that's what we're talking about. And do you feel you have adequate engagement of members with what you're offering them? The reason I ask that, by the way, the answer is no. Every single organization I work with would say no. But the issue is you begin to ask why, it unpacks the issues. You start unpacking, oh, well, that's why. It gives you a checklist of things to do. And then, of course, being data-driven and evidence-based is always a good idea. So comments or questions?
Can I? Go ahead.
What media? Oh, thank you. Do you have a sense of what role the media plays in adding stress? And also, I mean, I understand the COVID thing aside, but I hear a lot through the media with regard to crises and situations, as well as the entertainment media that talks about various kinds of what I consider stressors or conditions that people feel maybe they're inadequate about. Do you have a sense of what role generally the media plays in all of this, and also how that impacts various cultures, various communities of color as well?
So first of all, I would not say I'm an expert in that, but I do read, I see a lot and I read a lot, as we all do in this area. So a couple of things. Yes, for sure, the challenges that are creating so much mental distress obviously transcend COVID. COVID it was already pretty rough. COVID made it worse. But yes, we've got racial challenges that we're facing increasingly with time. We've got wars, we've got economic uncertainty, we've got housing shifting, we've got a lot going on. And then, of course, there's the social media component. And when you said media, I'm not sure if you meant social media or not, but that's, of course, disproportionately affecting youth. And that seems to be very serious, even worse maybe than we've realized. So, but in terms of the media, I think of the media, now I'm going to a little bit more. So those are just things that I've read and I see, and I don't know how you unpack all of that. It's rough. But I can also say that there's a tremendous amount of consumption around spiritual growth, nature, environmental issues. On the positive side, there's just sort of more of everything, kind of the strain and the desire and the seeking. We're seeing both. I don't know how it ends up. I'm sort of an optimist, but in terms of the role of the media, the problem is that, it's reflecting who we are. So yeah, it may reinforce some of the problems, but I certainly wouldn't pin it on the media. They're just kind of showing us what's going on. In terms of how the media impact with communities, different communities, no. If anything, I would say things are underreported, and I don't think they're probably doing enough.
Thank you. This is a really great presentation. I really appreciate the framework and all that. I guess the question I would have on your last point, data-driven and evidence-based, 20,000 or more vendors out there wanting to, and they basically all say that they are data-driven and evidence-based. And the question is, how are those defined?
Yeah.
Everyone defines data to make themselves look good. They look for certain things. So they say, well, our suicide rate is low. Well, we're hoping that there are some data points before suicide or homicide, evidence-based. Well, this has been reviewed and published. Well, published and peer-reviewed, and you look at criteria on simple questions, and the criteria seem to be different than what is actually evidence. So can you give us some maybe handles on how to approach this as we begin to think about it ourselves?
Yeah. Well, it's a great question. And I think it gets to the heart of a lot of this. In fact, I think one of the very first things that I said in the beginning is science is not that strong to guide you on all of this. We have lots of reference points and studies and individual technologies, but it's not like anyone's put all this together. There's no place to look at where it's like they solved the problem. We don't have that. So I wouldn't want to be at all misleading in response to your question. But that said, this is what I mean. When I look at data first, I'm looking at things like engagement. If you don't have people even engaging in this stuff, by definition, nothing's happening. So there are hard metrics you can look at. There may be soft from the standpoint of a clinical outcome, but everything from, are people engaging? Are they looking at themselves? How do they self-report on, that's why I shared a few numbers with you, which sort of a combination of data and outcomes around, is this helpful to me? Am I getting to the next step? Would I refer this to someone? And have I made a behavior change? But ultimately, the answer, I think, to your question is, and it would be really hard to do and it would take years, is to sort of tie all this back to claims data and productivity. And there are very few people doing any of that, and they tend to be, I studied epidemiology as a thing. There's a challenge here because we're talking about so many topics, so many people, that you're sort of, your specificity starts falling apart when you look across too many variables. So the challenge that we have is, by definition, anything that you measure was too narrow. So I would break it into two parts. I would look at engagement and the broad set of topics and self-reported, and then I would choose a couple of darts, what I'll call them, like burnout and claims, and I would dive in and do some research. I don't know much more that could be done right now. Yes.
Oh, go ahead.
I have another question. Thanks, sir. Do you have any thought about how we can resolve the lack of sufficient therapists available? I know that a number of my colleagues studied in that area, but not everybody went into practice, and it was very difficult to do so, and support for more therapists to I think join practices and things like that. But overall, if we have such a high percentage of individuals who are facing mental health challenges, what can we do to increase the availability of professionals to assist in this regard? Thank
So
you.
2 or 3 quick responses. One is, if we can help people do some of that self-triage so that on that big, long line, a few of them step out, maybe as much as 75%. That would be fantastic. Not that I expect 75%, but let's say you get 5% step out of line because they took an assessment, they realized they're not at high risk. They tried some things, like my son, that figured out good sleep and some music helped reduce his anxiety off his meds. He didn't go to a therapist, didn't need his medication. So, not to be too strong, but evidence-based self-help, would be the term that I would use. So, so that's kind of part one. It's like a drip campaign. You just need patience and you just need to continually communicate with your membership. We're here, it's safe, whatever your issue is, there's all of these materials for self-help. I think that will help some. The second is, I don't know how you magically create more therapists. I mean, that's a national problem and we seem to be going backwards, by the way, so it doesn't seem to be getting any better. But we could certainly start looking at making the appointments more efficient. And what I mean is there are a lot of missed appointments. There's a lot of inefficiency in the system. And so in the system that Shamar was talking about, one of the enhancements we hope to make down the road is to start pairing people a little bit. And we also think that maybe online, I have read, so I have some colleagues that are over at Headspace Health and some of these other online kinds of things. And one of the things that they're finding is when you sort of take the physical hassle out of going to like therapy and taking bus rides and these kinds of things, that you might actually increase, the amount of actual connection during therapy. So I would look at where the inefficiencies more than adding bodies. But one last thing, there is this layers to the onion, right? It's not just A or B. There is peer-to-peer support. There's health coaching. So it's kind of like physician light. You can kind of do therapy light. And again, depending on the issue and the risk level, I would have people, okay, if I was sort of just, playing God on this real quick, I would have all of your members take a full panel mental health assessment with over 20 scales, find out where they are on their risk level, and then make crystal clear self-help materials, all of this anonymous and safe, peer support, coaching, therapy, clinical, and I would just sort of tee them all up and I would just roll that out department by department. That's what I would do. Good luck with that. Okay. Thank you for having us.
Thank you very much.
Thank you so much, Derek and Shamar. It's really delightful to have you present that, and it is a conundrum, and it's nice to kind of tease it apart and hear somebody else's perspective on it. And that really is sort of the message of today, because some of these topics, we think we know lots of things about it, but when we get to hear another's perspective, then we learn something different. So our next guest speaker is Dr. Kevin Grumbach, who's a Hellman Endowed Professor and Chair at UCSF, Department of Family and Community Medicine. And he's going to present on the current and future state of the delivery of primary care medicine and how primary care affects health inequities and reduces total cost of care. And his research and scholarship on primary care workforce, innovations in the delivery of primary care, racial and ethnic diversity, community health improvement, which is where Kevin and I got to know each other really well because we were co-chairs of the San Francisco Health Improvement Partnership for a number of years. And I'm really happy to have him here today because he's gotten himself involved in a lot of the movement, if you will, on primary care. And I know it's a subject of passion to our board. So thank you very much for being here today.
Good afternoon, everybody. Wait, you need a stretch or we're good? All right. Yeah, stand up, take a stretch. All right. There you go. It's great to be here. It's particularly a treat to be here. Thanks. To be invited by Abby, who as Abby said, we worked very closely on trying to really look at the broader health of people living in San Francisco, particularly around health equities and how the various institutions in the health sector at San Francisco could work in a more aligned and collaborative way to really try to make a difference. So it's great to see you, Abby, and it's really Nice to be invited to join you. Yeah, so I'm going to talk about primary care. Let me tell you the vantage point I'm coming from. So I'm a family doctor, first and foremost. I'm also a resident of San Francisco, grew up here, spent most of my life here. Went to medical school here at UCSF and have been working at San Francisco General Hospital and UCSF Health for more than 30 years now. So part of what I'm speaking from is my experiences for a long time being a family doctor working here in San Francisco. Second, I'm part of an academic institution and large systems like UCSF and San Francisco General Hospital and San Francisco Health Network, trying to understand how do we get institutions to reorient the way they deliver care to be more primary care and patient-centered. I'm also, you should know, I'm on the board of Canopy Health and really excited that Canopy now has is one of the offerings for HSS for employees and retirees, but you should know I'm also then representing being part of a nonprofit health plan that is trying to meet the needs of your people you care for. And then this complements your role, right? You're the purchaser of health through the HSS system. So I think the real question is, how do we get purchasers like HSS, health plans like Canopy Health, and our affiliated sort of health plan partners, healthcare organizations, whether it's Kaiser, whether it's UCSF Health, whether it's Brown Toland, and then individual people working on the front line of care to actually meet the needs that people have for highly accessible, comprehensive, coordinated care. And really, the key driver of that is a very strong system of primary care, I would argue. And I think there's increasing evidence that I'll share with you about this. So let's get started. So Levi, so this is what I'm going to cover today. I'm going to provide some evidence about the case for primary care, why it is such an essential foundation for effective, equitable, and affordable care. We'll talk about the precariousness of this foundation and why folks in your system are complaining of how hard it is to get an appointment. Do you hear this from folks in HSS? The difficulty of getting access to primary care, turnover, oh, I had one and I lost it and I'm struggling to get a new physician or nurse practitioner, why that's the case, and then what we need to really do this at the national, state, and local level. And then Abby asked me to comment a little bit more about some health equity issues to make sure we're all doing what we need to do in all the places where we're involved to step up and promote health equity. All right. Let me know if these slides are too small to see. I know for some folks in the back, you need to bring your opera glasses to see these. All right, so this slide, what this is showing, this is life expectancy in the United States, which is a red line, and then these other lines are the other nations of the group of 7, essentially the wealthy nations across the world that we consider our counterparts economically. And what you see is this diversion of life expectancy as one marker of the health of the people of this country, where you can see you go back, you know, in the 60s till it's really about the 1980s, where our growth in life expectancy fell off considerably from the steady growth in life expectancy in these other nations. We currently have an average life expectancy in the United States that's 3.5 years shorter than the average life expectancy in these nations. We have profound racial and ethnic inequities in life expectancy, but even non-Latino whites in the United States have on average a shorter life expectancy than the average person in these G7 nations. So something is wrong with our healthcare system and our society as a whole, that we are not promoting health that's equivalent to that of comparable nations. Here, this is just, again, this data on life expectancy I just referred to by race, ethnicity. Now, here's the paradox at the same time, and again, this is not new to you. Yes. Yeah. I'm sorry. That is looking at average life expectancy. Yeah. Good question. I should include Asian would be up equivalent to Hispanics in the United States. So sorry, I will correct that in future slides. Sorry for not including that. So we spend 60% more as a percent of our gross domestic product on healthcare than any of these other nations in the G7. So we have this paradox. We spend so much on formal healthcare services, and yet as measured in something as basic as life expectancy, we seem to be getting such low value for that. So why is that? Well, multiple factors. I don't want to say there's one simple solution, but I would like to make the argument that one part of this lack of value for what we're delivering in healthcare is because of our failure to invest in primary care. What this slide shows is just the number of physicians per capita in the United States over time. The red line are primary care physicians. These are family physicians, general internists, general pediatricians. This line is non-primary care specialists, cardiologists, surgeons, anesthesiologists, dermatologists. And the green line is a total. And what you can see is, you go back 50 or 60 years and we had an equivalent proportion of primary care and specialty physicians. And what we've done over the past decades is build the specialist supply per capita and done nothing to invest more in an equivalent growth in primary care physicians. And now there's certainly a role for other professionals, nurse practitioners, physician assistants, other part of the primary care team. But even if you account for that growth, we still have very modest growth in the total primary care workforce. Now, I want to make sure we're all on the same page. What do we mean by primary care? Primary care is a function in the health system. Now, it is performed by some types of health professionals. So as a family doctor, most family doctors are involved in delivering primary care, but you may have a family doctor who's just working in the hospital. You have non-physicians, nurse practitioners. And so what we're talking about is the function. And these were defined really beautifully by Dr. Barbara Starfield, who's one of the gurus of primary care. And it's about accessibility, first contact. So primary care is you should be the portal of entry when somebody wants to access healthcare services. You start with your primary care clinician. That clinician should deliver, along with their team, comprehensive care, meaning primary care should be able to handle most of the problems that people have on a regular basis, whether it's diabetes, whether it's a stomach ache, whether it's a sprained ankle, whether it's mental health issues, as we just talked about at the last presentation. That primary care can deal with most of those things. And it's about continuity, a relationship over time where you get to know your clinician, the team, and feel you really have a relationship. And lastly, it's about coordination. So people will need specialty services, home care services, physical therapy services, behavioral health services. But the idea is you come back to your primary care medical home and that team puts it together to feel like you're getting care as a whole person, not a disjointed one organ at a time or one disease at a time. So you can say, well, emergency departments, don't they do primary care? Well, they do first contact, they're accessible, they do comprehensive, it's not a continuity relationship, they're not coordinating other services. So that's what's unique about primary care is you put all four of these together in one team that's meeting the bill. All right, let's talk about some of the evidence. This slide, it's not totally intuitive, but this was an incredibly powerful study that was published a few years ago that looked in this 10-year period between 2005, 2015, in all the counties in the United States, measured the change in primary care physician supply per capita in each of those counties, and looked at how that was associated with changes in life expectancy in those counties. And what the research showed was a very powerful effect. If among those counties, when they did all the distillation, they found that an increase of 10 primary care physicians per 100,000 people in a county was associated with an increase of life expectancy of 100 days. So that's about a third of a year. So this is in 10 years, you got an incremental gain of a third of a year of life expectancy if you lived in a county that had a moderate growth of primary care physicians compared to those who had less growth or lost primary care supply. They did the same analysis for specialty supply, much smaller effect on life expectancy, much stronger effect related to the supply of primary care physicians in that community. Second study I'll cite just came out, sponsored by the California Healthcare Foundation, that did a detailed look at commercial health plans in California. So I know Todd May's here from Health Net. So they looked at Health Net, they looked at United, they looked at Anthem, health plans serving in the private insurance sector, and looked at then the medical groups delivering care under contract to those health plans. And what they measured was what percent of every dollar spent by those health plans or those provider organizations went to primary care as opposed to inpatient care, as opposed to other, specialty care services. And they found that those plans and provider organizations that spent proportionally more on primary care as a share of what they were spending had much better outcomes, much better quality, a lower overall costs, better patient experiences. And the last bullet here was their bottom line. If they took all those health plans and the provider organizations that were in the low primary care spending and moved them up to the higher primary care spending level, they would project a big savings of $2.4 billion a year from shifting to a more primary care oriented way of delivering care. So why does primary care have such a powerful effect on health, on outcomes, and do it in a more affordable way? We have to realize, despite the challenges in primary care, half of all visits to a physician's office in the United States are to primary care clinician offices. So it means that's where a heck of a lot of care gets delivered, particularly preventive care, whether it's cancer screening, immunizations, and we'll talk about this with COVID. How do you really make COVID now just part of a routine part of primary care? Chronic conditions. Do you think most patients with diabetes are seen by an endocrinologist or a diabetes specialist for their care? No, the vast majority of services are delivered actually in family doctor's offices, in general internist's office. Same for people with asthma, lung disease, you name it. Depression. We just, again, harking back to the last discussion, half of all mental health services are delivered not in specialty mental health clinics, psychiatrists, social workers, psychologists. They're actually delivered in primary care offices because of the whole issues of stigma. Where do people go when they're depressed, when they're anxious? They tend to talk with their primary care clinician about that. And they're often the people doing much of the prescribing and counseling on mental health, behavioral health, substance use issues, prescribing now for opioid use disorders with buprenorphine being more available. A huge amount is delivered in primary care offices. So critical sector that makes a big difference. Equity. All right, I know this one is impossible to read. Just what this is showing is the relative number of visits to physicians in different specialties among Black Americans and white Americans. So this vertical line would be if the specialty had an equivalent number per capita of visits for Black and white patients, you'd fall right on that vertical line. The specialties falling on this side are ones that have a lower proportion of visits for Black patients relative to white patients. The ones on this bottom part have a higher ratio. And what you can see is if you look at primary care offices, family medicine, geriatrics, internal medicine, pretty equivalent. Whereas if you get into some specialties, dermatology, otolaryngology, other ones, urology, orthopedics, you'll see much less sort of parity of use of those services for Black and white Americans. Family doctors are the only specialties that are actually distributed across urban-rural continuum in the same proportion as the population in California and other parts of the United States. So if you go out into the Central Valley, and I know some of your members are all over, right? California, that's the only game in town. I mean, if the doctor who's going to be there in a smaller town in much of places outside of metropolitan California is going to be a family doctor or a family nurse practitioner or family physician assistant. If you look at federally qualified health centers, safety net systems, heavily reliant on primary care clinicians as the basic clinician workforce. So we have this incredible evidence on how important it is to have strong foundation of primary care while we're appreciating how precarious this infrastructure is. So I said half of the visits in the United States to doctors are to primary care physicians, yet we only make up less than a third of the physician supply in the United States. We Again, on average, in the United States, we spend 5 cents on the dollar of primary care. Most of those nations in our G7 comparison nations spend upward 10% or higher of their total healthcare budget on primary care. So we way underinvest in primary care compared to these other nations. Research, I mean, sore spot with me is somebody who does research, only 1 cent out of the dollar in all our NIH and HRQ awards go to primary care. You know, the pay differential, all physicians make a good living. Let me be clear about that. Family physicians make a very good living, but they make 60% on average of what physicians in other specialties make. And I'll get to this in a minute, why this is a problem for actually recruiting and retaining people in primary care. So there's a huge pay gap in primary care and non-primary care. And along with that, we see huge burnout rates. When you look at burnout, that was also mentioned in the last presentation. If you look at the physicians in the United States, burnout is highest among family physicians, general internists. They're like 2 of the top 5 specialties for burnout. So this is unsustainable, folks. So if you're wondering, why are your members telling you they're struggling with getting the primary care they need? It's because this infrastructure just is really porous. All right. This is Tom Daschle. You remember Tom Daschle? This is dating me, but this goes back to the Obamacare era. He was being considered for Secretary of Health and Human Services. But I thought his comment was so telling. You know, we have this upside down period. Most systems have a pyramid with strong primary care, then secondary, tertiary care. We sort of like start by investing in tertiary care, and then we let the trickle down phenomenon get to primary care in a very unsupported way. So the question I think for you all at HSS is, what role do you have to play into moving the system, moving the payers with whom you're contracting, moving the provider organizations, including my provider organizations, to put much more emphasis on primary care? Now, why is this necessary? Because primary care is a team sport now. This is a model, you see this kind of pyramid again. And if you look at a population like your members, you'll see a bunch are pretty healthy, right? New sort of routine, preventive care. And then some folks who have some risk for chronic disease, maybe smoke, sedentary, what have you. Some then get chronic diseases, then some get more complex needs, and there's some really, really high utilizers, okay? So you have to design a primary care system that can adapt to all these needs of the population served. So you need for sure, you know, physicians, nurse practitioners, but here you need like to really expand the role for medical assistants so that they can help with a lot of the routine screening for cancer service, delivering immunizations. You need to then start having people like health coaches who can work with people with chronic conditions like diabetes to work with them. How do you help folks take more control of managing their chronic conditions, depression, things like that? You need a whole bunch of other folks like behavioral health personnel now embedded and integrated in primary care to really have those wraparound services that complement what's being done, for example, by a family doctor. And then you need, you know, at the highest end, you need things like street outreach teams that are going to really help work with the patients who are least well connected with the health system. So this is where the investment has to go. This is why you can't just invest 5% in primary care. You need 10% to actually be able to hire all these types of personnel and deploy them in teams to comprehensively meet the needs people have. And this is the biggest, I would say, single most helpful thing could be done to reduce burnout in primary care is to not make doctors and nurse practitioners and PA feel so overwhelmed because they don't have all the supports there to deal with that patient sitting there who's depressed, who's got a substance use issue. And I say, you know, I got 20 minutes on my schedule. Oh, let me assess that, work with you. Can I now bring in the clinical social worker who can actually talk with you and provide some counseling? And then we have to address this income gap. The top line shows the ratio of primary care average earnings to specialist earnings. So you can see we're down around, you know, actually it's less than 60%. This is the percent of US medical school graduates going into primary care specialties. Do you notice a pattern between these two lines? Okay. When you suddenly see a dip as primary care earnings relative to other specialists go down, you see fewer students go into primary care. Then it starts to go up more students decide they're going to become a family doctor or a general internist. And then it starts dropping down, and that drops right down there. So it's very hard for me when I'm talking to medical students who are coming out of medical school, hundreds of thousands of dollars in debt, to say, earn, $150,000 less as a family doctor than you could make as a radiologist, as an anesthesiologist, as a gastroenterologist. So I think that's the other question, is to make sure this funds get moved to both hire more of these team members and to actually think about what's happening with primary care physician compensation. So what's happening at the national level? There was a National Academies of Science, Medicine, and Engineering report issued last year, very prominent report. The first line is their overall conclusion. Primary care is a common good. That was important to say. Meaning it's not a market commodity. It shouldn't be thought of as something that's, just part of market dynamics, that everybody in this country deserves and needs high quality primary care. And we should be collectively responsible to make sure that foundation as a public good is there. Just like we're collectively responsible for public schools and roads and safe bridges and air quality in our communities. This is a common good that we should all essentially own and be responsible for. They then had some specific recommendations, a lot about payment. Part of that primary care for teams, we need to pay more and we need to pay differently. So it's not just traditional fee for service, but it's things like capitation, ways of being able to pay so that it doesn't matter whether it's the doctor, the social worker, the health coach, that money is funding to the practice on a population-based method rather than just billing for a particular service that only doctors can bill for. Training, we really need to invest more in the workforce to boost that supply of primary care physicians and other health professionals in primary care, and several other things. And one of the recommendations was we need to make the federal government more accountable for primary care. Right now, there's no office in the federal government, in the Department of Health and Human Services, where there's a person who goes to work every day and his or her responsibility is to make primary care work for all Americans. There's the Center for Medicare and Medicaid Services, and they worry about Medicare and Medicaid, and somebody there is thinking about primary care payment. There's Health Resource Services Agency that pays for community health center funding and things like that, but it's all disjointed. So one of the recommendations, which is being taken up now by the Office of the Assistant Secretary of Health, is to actually have a primary care office under the Secretary, which is responsible for holding all the stakeholders, private health plans, public health plans at the federal level, in partnership with state plans like the Medicare's partnership between the feds and states on Medicaid, to strengthen primary care. They're going to have a report to be delivered to Secretary Becerra in June. Let me make a pitch for HSS. Watch for this, okay? Watch for this report. Actually, it would be helpful for an organization like HSS, when that report is issued, to submit a letter to Secretary Becerra saying, for our members, we totally agree that we need to strengthen primary care and have more federal attention to this. And we highly suggest you adopt the recommendations coming out of this work group in the office of the Assistant Secretary of Health. Something to think about. So what about California? Now, I shared the slides with Abby, and she said you guys are already actually well aware of what's going on. It's been very encouraging to me. There's this primary care investment coordinating group that includes people from, I'll show you who's on it. It's a lot of the private and public players, along with consumer advocacy organizations and foundations like the California Healthcare Foundation, that are doing the same thing like we proposed for this national coordinating council, to have a coordinating council in California of the multiple stakeholders to, again, single-mindedly focus on what do we need to do in California to really solidify and improve the primary care infrastructure, and to align and coordinate all these strategies. So I think I would also encourage you to think, what's your role within this emerging coalition in the primary care investment and coordinating group? So here's some of the folks, as folks from Department of Healthcare Services, you can see Covered California, Purchasers Business Group on Health, CalPERS, so forth are represented on this. So I think you are actually, in many ways, connected with this. So what did they recommend? Well, there's already action going on that you should know about. Groups like Colored California and the exchange programs with CalPERS, with Medi-Cal are saying we're going to align our measures for primary care and contract language. So we have some common way of talking about it and measuring what are we doing in primary care. Covered California, and kudos to Dr. Alice Chin and Dr. Lance Lang, who I know has worked with you all some, who is her predecessor as medical CMO for Covered California, have said we're actually going to require all the contracted plans under Covered California to tell us what % of your spending goes to primary care. Is it 5% like the US average? Because we saw this big variation from that study in California. Are you at 5? Are you at 8? Are you at 10%? We actually want to know this. So again, how are you working with your contracted health plan? Should you be thinking about, tell us on an annual basis what % of your expenditures are going to primary care? CalPERS. Now, I think all your plans, Abby told me also, you're all in a managed care kind of delivery system, I think, pretty much, because for PPOs, there's also now a desire to say, actually, people do need to declare a medical home, even if they're not in a managed care one that requires it. But it's good for everybody to say, here's a place that I know I can go to for my primary care, and then that place knows that they're accountable for meeting your preventive care, your chronic care needs, and other types of needs. So push to kind of move the PPO market this way. Department of Healthcare Services is really starting to require for all its contracted, like Medi-Cal managed care plans, to do the same thing. Reporting on primary care spending. What are you doing to address primary care access? PBGH, again, common purchasing agreement on primary care. And then, are you keeping on top of this whole California proposal, AB 1130, to have a Department of, or an Office of Healthcare Affordability? I guess you actually may have some mixed feelings about this, on some pros, some cons, but one of the good things is in this office, there would be something equivalent to that National Primary Care Office to really, for the first time in the state government, say, here's an office within this new office that really would be single-mindedly focused on primary care. So whatever you think about the overall package there, that I think would be something worth supporting. So the final recommendation. So again, I think, how could you potentially get behind these with your role as a purchaser? Measuring and reporting primary care spending. Again, just starting there, not stipulating it has to be 10%, but just at least we want to know what you're spending on primary care. Then moving towards some basic target we're looking for, or at a minimum, a floor. We expect, if you're a contracting plan, we expect this much of your expenditures to go to primary care. To really encourage your plans, working with the pay or alternative models. Now, I know Kaiser is a big player in HSS, so Kaiser's already there. I mean, they pay on a population-based basis. They are more primary care oriented, in all honesty, than a lot of other organizations in California. So it's almost, how do you make sure all the other systems you're working with move in that direction? Benefit design. Do you guys have big deductibles in any of your plans, or pretty low? So yeah, so that's really good. So that you realize some of these PPOs have $5,000 deductible. Even Covered California had big deductibles under the bronze plans and things like that. Of course, they're waived for a preventive care visit, but what about going to get my check for my diabetes or my blood pressure or for my depression? That would have a huge deductible share until you met your deductible, or co-payments and things like that. So again, there's a big push. We should actually broaden it just from preventive care to, frankly, all primary care services should be exempt from deductibles and large co-payments. Probably not so relevant to your plans. And then to track progress, that one of the National Academies recommendation, there should be an annual primary care report for the United States. How many primary care clinicians do we have per capita? Physicians, nurse practitioners, others. What's our average spending? How are our quality metrics? How are we doing on prevention? These kind of things should be in a regular reporting system that we should have in California, so we know, are we making progress on these domains? All right, I really highly recommend this new website that the California Healthcare Foundation just launched. It's called Primary Care Matters. Just Google California Healthcare Foundation, Primary Care Matters. Wealth of information, the research on this, a lot of what's going on with these state initiatives, a really helpful website that's most welcome here in California. All right. just let me now just close, because I want to touch on some of the health equity things. I've already talked, primary care is actually a key part of health equity, because that's where people start for their care. And the people, higher SES folks will figure out how to navigate the system. Again, weak primary care really puts people at a disadvantage who have limited English proficiency, who have other barriers to accessing care services. But there's more to it. So first point is, you all are thinking about how are you in equity promoting health system services? And this is what I've seen from my research and racial, ethnic inequities exist. They're ubiquitous. They exist among the general population. They exist among Medi-Cal beneficiaries, but they exist among privately insured people and retirees. No matter where you look, you will see racial and ethnic inequities. There's also class inequities. There's other inequities on basic factors, and they're intersectional. So if you're low income and a BIPOC racial ethnic background, you will likely have more disparities than somebody who lacks both those identifying characteristics. And as I say, they exist for employees of San Francisco and retirees, just as they exist for employees of UCSF and retirees of UCSF. And I'll give you an example of this from my own organization. So let me just do a little case study of COVID among the patients we care for at UCSF Health. So UCSF Health, a mix of commercially insured, Medi-Cal, Medicare beneficiaries. And when we looked in the early phase of the pandemic, we noticed that about 12% of the patients we serve on a regular basis in primary care and specialty care at UCSF Health are Latino. Next, what percent of hospitalizations in the first 6 months of 2020 do you think at UCSF Health were among Latino patients? So 12% of the patients we serve are Latino. Anybody want to make a? Okay, so it's 40%, but it's very high. So the same thing we saw in San Francisco, right? It's not like, oh, well, that's just patients at San Francisco General Hospital or something. It's true in our patients. The same thing would be said of Kaiser patients. So huge disparity, and we still have a higher hospitalization rate among African-American patients relative to their share of our overall patients served. So these are the data I just referenced. So you can see here's the blue bars are these groups as a percent of the overall patient population, and this is the red bars as a percent of the patients hospitalized for COVID at UCSF. As I say, this bar, there's been more of a disparity that has grown over the year since these data, a year or two since these data, we started first collecting them. Okay, vaccination rates. What happened with vaccination rates? This is among patients served by UCSF Health. So this is the blue bars are Asian, this is African American, Latino, this is multi-ethnic, this is Pacific Islander, Native Hawaiians, and this is white. So what you see is a percent of folks with a primary vaccine series completed. And so you can see, again, the same thing among all our patients. Look at the gap between just using whites or Asians as a reference population, and look particularly among African-American patients. It's sort of narrowed a bit, but even in a couple of months ago, still prominent gaps. This is, again, under 64. So these are working, more working age populations, less prominent disparities, but still exist in the 65 and older group. Now, we've put a lot of effort, but we're slow. We wait for the disparities to hit us in the face, and then we said, oh gosh, we better do something about this. We're trying to move to an equity first model where you don't wait for these things to manifest themselves. You say, how, when we first start working on immunizations, are we going to actually do it in an equitable way? What do you think happens when you require everybody early in the pandemic to schedule their immunizations online, right? How many of you tried to use My Turn to schedule your immunizations for COVID? How many times did you have to reboot that screen to do that? Same thing UCSF. You had to go through the patient portal to schedule it, so forth. Who is disadvantaged by relying on digital modes of scheduling vaccinations? It's people who have limited English proficiency, people who have low income, don't have good broadband access, people who just don't have, the smartphone or computer to do this. So is it a surprise that you see these big racial ethnic inequities appear pretty early on in the vaccination process? It's not a surprise. So we need to be thinking, we kind of know this. How do we then build in alternative scheduling ways right off the bat instead of doing what we did, which is months later, so, oh, we need to actually call people. What a shock. Pick up the telephone, or even used automated calls were pretty successful. But how do we reach patients in a way that's going to work for them? So we've used this, we're trying to adopt now this equity first model, which you may want to think about in your own approaches, which is how do you build equity first into everything you do rather than playing catch up? And this is things like equity leaders on all planning and implementation groups whenever we're thinking of a new initiative, building the capacity for everybody to understand the importance of equity and what it's about. You have to invest in this. I mean, a lot of the work we did required resources to do the outreach necessary to reduce things like COVID vaccination equity gaps. Holding leadership accountable, like having measures like what % of people are we vaccinating and what is our goal to reduce these inequities and making sure our teams are responsible for getting that done. Partnership, as we talk about with patients, with employees, with providers. The other thing, our employees were similar with the vaccination rates by race, ethnicity. Now, with a mandatory vaccination requirement, people did get vaccinated, but in the first months of the vaccination command, the same racial ethnic gap showed up for our own employees. So that's, I think we're thinking we need to do better, and we really need to shift our whole paradigm for building equity as an upfront equity first approach to everything we do in the health system. All right, so let me close. I'm gonna come back and then close on primary care. People know Michael Pollan. Anybody ever read Food Rules or The Omnivore's Dilemma? So he started, he's in the School of Journalism at UC Berkeley, started writing about food. He's now kind of moved into psychotropic drugs and hallucinogenic drugs. So I don't, it does. And maybe that's equally relevant to primary care. We need a little more psychedelic assistance. So he, in his food rules, he had these 3 food rules, very simple, which is actually what I tell when I'm talking with patients, I actually don't do a lot of detail. Well, try this. I say, look, just eat food, like meaning real food, not something processed, like something you can buy at the farmer's market, not something that's, you have to rip open multiple layers of a package to get to. Not too much, don't supersize everything, mostly plants. It's fine, want to eat some meat here and there, not trying to be overly prescriptive, you have to be vegan, but like predominantly go for a plant-based diet. That's healthier, right? Pretty simple. That's a healthy way of eating. All right, let me give you my prescription for the health system. Get medical care, not too much, mostly primary care, all right? So again, for you all, what role do you have to play at HSS in making the health system look like people can get medical care in an accessible way when they need it? We don't overutilize things and spend a lot of wasteful expenditures on things that aren't actually benefiting people on a system that is much more based on a strong foundation of primary care. Thanks for inviting me to share some thoughts with you.
Open up for questions. We have some time.
Perfect, yeah.
Yes.
Was that? Yeah. Yeah. I'm gonna think. So it's really team-based care. So that's what we're talking about. So right now, obviously, let's say the family nurse at the dental hospital.
Could you maybe either take your mask off or speak into the microphone?
I'll say, yeah. So if you come see me, I can bill Medi-Cal if you see me, but I can't bill for a health coach visit that same day. So this would say, no, pay a capitated rate. And again, Medi-Cal, the San Francisco Health Plan is moving this, but so then I can just, whatever services I need to deliver, I can deliver that. And whether it's me, whether it's a pharmacist and things like that. So it's getting out, largely it's about getting out of just pure fee for service mode, which is, just pays for largely the licensed doctor to bill towards patients who are registered with a practice. That's why even a PPO is trying to get people move there, and then say you will get maybe still a little bit of payment based on the visits, but most of it will be on how many people are enrolled. Let's do a simple case mix adjustment, not based on how I can overcode all the diagnoses, but let's just look at the census tract. And you get paid more if you're seeing somebody from a low SES census tract where we know there's going to be higher needs than if you see somebody from a higher SES tract. So move to that. And then probably with a third component that sometimes just we're going to give you outright resources to hire a pharmacist that will work with these practices so that they can manage medications with you for patients who have a lot of complicated medication needs. So does that help get at the question? Good.
My question is, I think, somewhat related, because I hear you talking about billing and how to get paid for your services. I'd like to know if you see a role for physician assistants and maybe it's nurses, but I think there's a profession of physician assistants that in some countries deliver a great deal of primary care. And I'm wondering if if you consider that a possible or a possibility to helping with the problem of insufficient primary care physician and services available.
So absolutely. So that's why I was very careful in my language, not to just always talk about, it's just about physicians. So when I talk about primary care, I'm actually counting all those physician assistants, nurse practitioners, other health professions working in primary care. And even with that, we don't have enough people in primary care. And what we're seeing is the same income differences are affecting physician assistants. You can make a lot more working as an orthopedic physician assistant than you can as a family doctor physician assistant, because that's where all the money goes. And it's frankly a little easier to work in that sector. So we absolutely need all the different health professionals working together, team members, and even with that right now, we're a long way from where we need to go. Is that?
Educate individuals about, because many of our members will take a look at a roster within a health plan.
Yeah.
And they've even said, oh, I'm looking to see how many specialists.
Yeah.
And if they don't see sufficient specialists, they don't want to go to that health plan.
Yeah.
And yet, in our discussion today, and it's very clear that your primary care is where you need to start and it's your most important.
Yeah.
Do you have any suggestions as to how we can help re-educate our members, or actually the population as a whole, that it's primary care that is primary?
I do think we need to shift the culture. You're right. Because people have been, dare I say, indoctrinated, no pun intended, in a kind of, it's all about, and we need specialists. I know Dr. Follenby from years, working like ID specialists, others, but we need it, but it's sort of the proportion of things, and that people have undervalued the importance of having a really good primary care medical home. So I think it'd be great for you to reinforce that message, to share some of the evidence. We then have to deliver the goods. So then we have to be accountable for giving people a great experience when they come there and be able to say, yeah, actually, I know how to deal with that rash without you feeling you have to go to the dermatologist. No, I can help you with your shoulder problems. You don't need an orthopedist right away. And if it's not getting better, then, well, you may need a referral to an orthopedist or a physical therapist. So I think the more you can keep hitting home on, we think the best thing for your care is to make sure you have a really highly accessible, great primary care medical home with people you can trust and adequate access to specialists when you need them. I'm also starting to launch a campaign where we actually capture the public voice on this, because too much it's people like me talking about this, which sounds a bit self-serving. So I'm starting a campaign to bring in patient and community voices to say, in short video sound bites, tell me why primary care is important to you. And I'd love to start building like a social media campaign to really get the work out. So you might even want to think about with your members, is there social media, is social marketing to have, but I think to capture the member voice, to say, this is why this really worked for me to have a wonderful primary care medical home. And I think all of you should make sure you have that too, to get great care.
The incentivization by census tract,
Yeah.
are you aware of that ever being
Yeah. Yeah. In the country, it's starting to be done, but it's done very much as standard practice in Britain and many other European countries. Shockingly enough, like, why are we like insist on being exceptional? So it's been longstanding in National Health Service as if you're a general practitioner, that's how they adjust the capitation payments because it is capitated. Everybody has to enroll with a general practice. And then it's based on 80% of that capitation weight is based on your residence and the socio-demographic characteristics of that. This has been strong proposals coming, a lot of this federal recognition like Medicare. I don't know if you're keeping track of Medicare Advantage stuff. I mean, it's become a scandal, which it's all about how you game the system for their capitation rates from Medicare to the carrier. You know, Medicare as the federal payer subcontracts with Medicare Advantage private plans, and the more they can kind of make the patients look like they're really sick, they get more money from Medicare. And you can game that system by like, oh, that, you know, it's that really complicated diabetes because you once said you had a little tingling in your finger, so you now have diabetic neuropathy, not just plain diabetes, and get a much higher risk score. So as opposed, I think there's a push to say, no, base it much more on where the Medicare patients reside with maybe a handful of diagnoses that would contribute. So it's not just theoretical, it's been proven in other countries, and there is more dialogue going on now. And I think that's also to think about with your how you're approaching your payment rates with plans is whether this could be part of it.
Can I, thank you very much. That's a
yeah.
great talk. And you you brought up a lot of issues
Yeah.
that can seem almost overwhelming to us, certainly as a board and health
Yeah.
service system. You know, and a lot of it is around, as you pointed out, is around terminology. You know, we have tended to use the term, you know, PA, physician assistants and nurse practitioners, or even medical assistants as physician extenders.
Yes. Yeah.
And that is, you know, that is not what you're advocating.
Oh.
And part of the problem, my guess is that medical assistants, there's not even even though there's schools to get a degree, to get a license to do that, but they're not standardized practices within systems. And so I guess I would just point out that having spent half of my professional career in fee-for-service practice and half at Kaiser, I have seen both sides. And I'd be curious to know, if I were still working at Kaiser, how they would code me if they were asked, how much do you spend on primary care? Because I was hired as one of 2 ID doctors as a primary care doctor. I was told outright, you were being hired to do primary care. And so how we get health plans to agree on definitions, number one. I'd also point out that I know certainly within the Kaiser physician group, the morale may be incrementally better. The pay differential between the primary care docs, which includes pediatricians and family practitioners and internists and OB/GYN, and the high paid, is actually quite narrow compared to some of the gross numbers you say. And yet the morale is incredibly bad around primary care. And some of it has to do with the expectations about how this access. And you highlight over and over again, 24/7 access. And at least when I left Kaiser, the system did not allot any time for providers to handle all the doctors' online messages. We were told what the criteria was to get back within 48 hours, but there was no pay for that time. And so many of the primary care docs would go home, put their kids to bed, and then work 2 or 3 hours.
Pajama time, we call it.
Sorry?
Pajama time. It's
Exactly, pajama time. And so a lot of people are choosing the subspecialties because they have very fixed hours and very fixed expectations. And the last thing I would point out also is that it's not simply the list of subspecialists and super subspecialists, it's access to them. And one of the things that Kaiser, and the example that I'm sure you're aware of at Kaiser, was that years ago, the medical center in San Francisco instituted what they called the sort of roving or consulting dermatologist. And even though San Francisco has lots and lots of dermatologists, you go in the pages and look, but try to get an appointment for an urgent dermatologic problem in the fee-for-service business. But at Kaiser, what they piloted, and now is national, is that a dermatologist will come into the primary care office and look at a suspicious lesion. And who gets the most satisfied? The doctors get somewhat satisfied, but the patients
Yeah.
loved it.
Yeah.
And it was met with a lot of suspicion
Yeah.
among the other medical centers, but it was adopted.
Yeah.
And so it's about access. It's always about access.
Yeah.
It's not about how many cardiothoracic surgeons you have. It's how do you get in touch with them?
Yeah.
And can the member know that you've talked to them? Sometimes when the member's in the room.
Yeah, or even an e-consult. Yeah.
Exactly.
Yeah.
And so I just point out that this is a very complicated
Yeah.
system.
Yeah.
It requires a system.
Yeah.
And I think you've given us a lot of fuel
Yeah.
to sort of look into this, but I'm not sure where all the answers lie.
I your insights all resonate with me, Stephen.
Yeah.
And it's complicated, but I do think it still comes back, we got to support primary care better.
Yes, absolutely.
I just think everything then starts to unravel without it. And so I think that's back to you all is, can you play a role in, and I'm almost inviting this. I see Keaton here, my colleague from Canopy Health, is like, how do you make sure we understand this is a priority for you if you want us to compete successfully for members through your contracts, right? I know open enrollment period, we were stuck a little bit because members who wanted Canopy were struggling to find primary care in San Francisco. So like, how do you say this is not good? If you want to, Canopy to work for HSS, what are you doing at Canopy? Keaton, don't quote me at the next board meeting that I set this up, but other plan folks, and then even to me, because then Keaton and Canopy Health and when I take off my board hat, I go back to UCSF as one of the participating medical organizations. And I said, oh, Canopy is pressuring us to do better for primary care. Okay, UCSF Health, how are you making sure we have the supports in place for better communication with specialists? So I'm actually inviting you to be part of this pressure that then will start to be applied at multiple levels to, I think, move the system where it needs to go.
I think you touched on the debt that someone incurs as they go through medical school as being a driver that may, cause a young emerging physician to become a specialist rather than a primary care physician. Are any of the initiatives that you talked about trying to make the educational process more affordable? The fear is that, very talented individuals may be scared off just because of the debt requirements. My daughter is going through medical school, so I know what she's incurring. I'm curious for your thoughts because that really is the future generation of what can build primary care. But I can tell you like how much anxiety she has about the debt that she's incurring to become a physician.
So I mean, that's poignant. So it's these real issues, what I want to do with my life and where my interests are and how do I reconcile this with the debt I've accumulated? So I have to start by saying again, do you know the other difference between us and the G7 nations? Medical education is virtually free in all those countries, okay? You can go to Oxford University Medical School and pay virtually no tuition. It's actually a public university. It's considered a public good. Now, again, there's less opportunity to become a cardiothoracic surgeon when you graduate from your training in United Kingdom. That's part of the social contract is it's free, but then, we actually think more of you need to go into general practice and not so many in these fields. So that's just, I went to UCSF Medical School and it was actually when, so I started in 81. I paid less than 1/10 of what someone of your daughter's peer group is paying now to go to UCSF Medical School. So that is, way above inflation. So again, we've sort of retrenched on just our investment in public education, higher education. Anyway, but that's a long story. The short story is there are some programs, like particularly if you're willing to work in a underserved community, there's a few clinics in San Francisco like South of Market that may qualify. Often it means going to a little bit more less urban place that you can get $150,000 of debt eliminated within 3 years. So that's not bad. There are some now state programs and some more state money going into some loan repayment program that prioritize primary care. I think the state, as part of its workforce policy, I'm on the new state workforce council, should be looking at how do we amplify that. So I think we do need to do better with loan repayment programs and make it so you may not have to go to the most remote place to be able to get at least, a good chunk of your debt repaid. I still think it'd be much better at the front end to not just make people come out so indebted. University of Massachusetts Medical School, which is a public Massachusetts medical school, your tuition is waived if you stay in Massachusetts and work as a primary care physician, no matter what community you're working in. So I think there's some models we really should push on, and that'd be another thing for state policy is how do we prioritize more of the loan repayment broadly in primary care? Yeah. Cool. All right, we solved the problem? Yeah, all the problems now, Abby? We solved all our problems? All right. Yeah, Abby and I take on, yeah, all right.
Yeah.
We don't want the small problems.
No,
All right,
no
good,
small
yeah.
stuff, just
Thank-
big
Thanks
stuff.
for
Yeah,
inviting me to
yeah,
spend some
yeah,
time.
you're welcome. Welcome, thank you very much. Yeah. We have another group to have a conversation here in about 15 minutes and need a break. So I think I'm going to defer having a little discussion about what we've heard here until after that takes place. So let's take a quick break and come back in about 10 minutes. Does that work for folks? 3:10? Thank you.
Very good.
Yeah. Yeah. I'll come back to them at some other
Okay.
time. Very good.
I mean, that's fine. I don't even have it on. Okay.
I wasn't sure if you had to like turn it
Okay.
on or put it on, so.
Yeah.
Thank you very much. Thank you.
I love some of these ideas.
Hello. I'm good.
Yeah. Very. Yeah.
Busy, I'm gonna take it off.
All right.
Thank you again. I really appreciate your very comments.
Never be on time now.
That's the good news. Board members all do an assessment. I mean, there's three of the members are in that. Engage.
Every other center you'll do. I agree, and I'm not saying you folks doing the assessment, although that's still on the board, you know, a message from the board, you know, whatever. 3 or 4 of us did this. But I agree with you. And leadership at the department level and people, and there can be little task forces out there that already are.
Yeah.
And representing different groups.
Yeah.
I'm not sure entirely. I can mute that.
I know.
Mic check, mic check. We're going to be reconvening, so give yourselves less than a minute to come back to your seat.
And I think before we officially convene, I would like to just do another roll call for board members.
So thank you, President Fallsby. Roll call. President Fallsby.
Present.
Vice President Canning has departed for the day. Commissioner Breslin. Commissioner Howe. Commissioner Scott. And Commissioner Zavansky. President Fallsby, we have quorum.
Great, thank you. So we'll now move on to the second part of the program.
And before we do that, just a little check logistics. We've recentered ourselves into the center for the next portion, which will be a conversation, and we'll be moving our portable mics to our participants. We have 4 that will be passing that you all can pass to each other. And then when we move on to any discussion, a larger discussion, we'll resituate those mics. And we have 2 people, if Rin and Olga could raise hands there's Rin and Olga. We'll be available to pass those mics to people outside of the circle. So we'll readjust ourselves now. And I will pass this over to our next facilitator, Leticia Harris.
Good afternoon, everyone. My name is Leticia Harris. I am a senior health program planner and racial equity. Can you all still hear me? Racial equity lead with SFHSS. I have the pleasure of introducing our well-being at work conversation that's taking place at the center of the room. It involves a small group dialogue among colleagues. This discussion takes place in full view of the larger group, in this case, today's HSB audience. Participants have been provided with conversation cards to foster more dynamic participation, while the audience actively listens without comment. And to support this, we ask that you refer to the handout that's been provided, either on your chair or in front of you, specifically the observer questions, and please use the written notes section to capture your reactions and thoughts. The power of this conversation technique is in witnessing the dialogue, not having the immediate chance to respond, and opening our minds to new perspectives. This conversation brings together a broad set of thinkers and perspectives, and as the conversation unfolds, the conversationalists will introduce themselves, their roles, and dialogue with one another around topics like health equity, access, engagement, partnership, and best practice. Through this dialogue, we will observe challenges and opportunities that help us imagine the future state of SHHS benefits and programs. Conversationalists, take it away.
Okay. Is this working? My name is Sergeant Art Howard. I'm with the San Francisco Police Department. I work in our behavioral science unit. which is basically our peer-driven employee assistance program. It's been around since the early 80s, its initial inception. And so it's been great partnering up with HSS, especially during the pandemic. And so, the first question, what concerns are you seeing, hearing about the health and well-being of your workforce? I mean, you name it. It's, between, the pandemic, the civil unrest, the vaccine mandates, there's just been a lot of internal, you know, uh, pros and cons, both sides of the issue, folks struggling. And so we're having retention as being our big problem right now. And so, unfortunately, our profession got vilified, and so it's getting really hard for us to, attract folks and retain folks. And so one of the things that we're actively doing is doing resiliency at the station level, going out and bringing a clinician, doing a 4-hour resiliency at every watch at every station. But in terms of partnering up in the initial beginning of the pandemic, the health service system, Abby and Carrie, we got an app for our department phones and for our personal phones, a wellness app, going back to kind of what we were seeing in these previous slides in terms of self-care. So there's this app was developed by a psychologist. So if somebody doesn't want to necessarily call, they can go onto the app and get resources, do assessments, wellness toolkits. But ultimately, if they want help, there's 24/7 access. So, HSS has been a great partner through this for us. I know we've worked closely with fire and sheriff and DEM to, try and get these resources, engage the folks through our well-being teams and other opportunities. So, in terms of, I love to hear what other people have to say in terms of collaborating as we move forward.
Well, let me take this minute to thank you, Art, for all the help you've given the fire department. You work for the police, but both behind the scenes and in front, you've really helped our department a lot over the last 2 years, because our department, the fire department, culturally was not prepared to address mental health until recently, because we've had to. And that was starting to happen before the pandemic. So I don't want to say the pandemic forced it. It was starting to happen. A peer support group got set up, and peer support trainings, and a critical incident response team got set up, which was long overdue, really. I don't know how they've gone this long without it. But the pandemic brought everything crashing down, just all the stressors you just pointed out, both the civil unrest, what's going on in the streets with the fentanyl crisis. The vaccine mandate was more of a stressor than I could have ever imagined, and it was very difficult for me as the department physician, and I'm still feeling the fallout from that. So all of a sudden, everyone in our department is very interested in mental health, because like you, we have a staffing shortage, and a lot of people have gone out on stress leave and mental health leave. And so we're taking a lot of looks at all the levers that we can use at our disposal. And some of it is really, very organic, peer support driven. And quite frankly, that's the best, because it's a very strong culture. Fire culture is very strong. So the help is best delivered from within. But then the next level is to use the resources allocated in our department. So we have a Office of Health and Safety, which is run by sworn members of the department. And then there's my office, the physician's office, which traditionally has been a big obstacle to getting care, because the physician was regarded as somebody who could terminate your career or impair your ability to keep working at the level that you wanted to. And I think the first thing I did as a complete newbie to this space because I was an ER doctor for 15 years, was I came in with the idea that I'm here to partner with you on your health, and I'm here to help you access the care that you need. And it's taken me 2 years to I think Dr. Grumbach said in his talk that once you lose trust, you can't regain it. And boy, I have really, really, really felt that as the department physician. I'm just now, 2 years later, gaining the trust of the membership, but I have a long ways to go. I don't want to talk too long because other people probably have a lot to say, but I view workers' compensation as a very important partner to us. However, I think we are overutilizing workers' compensation in our department. I think we need to go upstream from workers' compensation and get people help before they need to go off work because of, mental health or stress. And we need to utilize primary care through HSS far more than we are. And I have a number of ideas about how to do that that link to, pay and promotion within our department. But poor workers' compensation has been carrying a very heavy load for the first responders in San Francisco. Would you agree, Art?
Well, and one of the things, so we have a clinician group of 30 clinicians we refer to, and they work with other workers' comps, and they really do give high praise to our workers' comp.
Yeah.
Because of the responsiveness, that the workers' comp has, and the way they take care of, especially around now the PTSD is presumptive for first responders, and so all these things. So it really is, we're lucky to have the folks there. But I agree with you, primary care, that is where it's at.
Thank you.
Well, thank you for that. Hello, everybody. I'm Peggy Sugarman. I'm the Workers' Compensation Director for the City and County of San Francisco. Just on this first question of the concerns that I'm seeing and hearing, certainly we've had a huge increase in the volume of our claims. A lot of that is COVID, but there is, I think, starting with the concerns, there's a lot of fear about the implications of getting COVID. And so that is kind of stoking a lot of anxiety just in the population of people who are getting COVID. Secondly, what we are seeing is very long disability duration. What do I mean by that? I mean that people are staying off work longer than ever on disability. There's seems to be hesitancy among the primary care doctors who treat for workplace injuries and illnesses to keep people off longer. We're having a hard time. And there are long-term effects of people being off work for too long. You start losing your connection to the workplace, to your peers, your physical health starts declining. And there's many studies out there that show that the longer you are away from work, the less likely you'll get back. And you may never recover financially from the effects of being on disability benefit as opposed to your full salary. Other concerns that I see, and then I'm going to pass the mic, is just a real fear among employees of being assaulted. So aside from our first responders, we have a lot of assaults that we see in our patient care assistants, our nursing assistants, just in general out on the streets. Sometimes if you're just walking down the street on your break or on your lunch hour on your own, that's not a covered workers' compensation claim, generally speaking. And so, but we're hearing the fear in addition to seeing the number of assault claims just rising in the city, citywide. So I think lack of providers for treating lack of mental health providers has been a key problem in workers' compensation cases, with a lot of our healthcare providers not being able to provide a mental health provider, and a real reluctance among other providers to treating workers' compensation patients.
Hello, everyone. My name is Tony Rucker, and I'm with the San Francisco Department of Public Health. And thank you. Good afternoon, everyone. I'm Tony Rucker, and I'm with the San Francisco Department of Public Health. And it's a pleasure to be with you all this afternoon. And it's great because I've worked with many of you, actually, just talking to you all, of course, many times through the 2 years of the pandemic. I'm with the Department of Public Health, and I'm from the Office of Health Equity. And I actually had the opportunity throughout the pandemic to be in a pivotal role of testing for the city. So I worked with Peggy on many occasions, and many of you, your colleagues, police, fire, DEM, et cetera. And we were in charge. I was doing the management and planning for health operations for testing for the city. So working with all of you has been a pleasure. And so it's really interesting and important that we're here today to have this conversation. And so the question about the concerns that we're seeing from our workforce, I can actually say that I was just back from deactivation on February 28th. So I am just back to my regular work, and it is just absolutely pivotal that we have this conversation and do some critical planning and strategizing for our workforce. Because I can tell you all that the DPH workforce is just absolutely just at its wits' end in terms of just the stress and the strain of the last 2 years. And whether you are direct care physicians or you've been folks who've been allocated and assigned to our communities, it's just been taxing. So the physical toll and the mental and emotional toll has been really impactful for our population. And it's really important to think about us. We have so many sections, and part of that is mental health and behavioral health units, and we're there for the clients and doing the work that we can. And you think about the pandemic, very much service outward facing in terms of the work, but there's been very little inward in terms of taking care of ourselves. Folks that have been on the direct front lines for this work, and the emotional toll, the physical toll for myself. I mean, and it's just amazing in terms of just coming back to the workforce and just realizing the impact physically. So for us, what we're seeing is just the mental health and the physical toll of the last 2 years, and coming back to exactly what you've described, the addiction crisis that we're seeing in the city, the homelessness. And we're right back to a higher intensity than ever of the health of our San Francisco residents. So what we're seeing and really wanting to make sure that not only our most impacted communities that we've been servicing throughout the pandemic, but just everywhere, the physical toll and the mental toll, and how our workforce not taking care of themselves. And so when you're talking about reconnecting to your primary care physicians, in terms of just having the humility and just the time just to be able to even focus on physical well-being. So I think it's so important to come back with HSS to really do some strategic work about how do we reconnect with our workforce and encouraging them to tap into their primary care resources. And then thinking about what do we have available on the mental health side in terms of our primary care providers and whether our healthcare, that they're able to access that. And will they be able to access that in the timely fashion that's needed, not only for the individual, but for their families as well. So I think that is something that's critical because we are such a service-oriented workforce. And so whatever we're doing, what are we doing for our families and our children and our spouses? And that's so critical because it's just part of how we function and how we having those resources available for our extended networks. So I think that's critical, and working with you all to partner and how do we begin to tap into that and to realize what are the limits of that. And so how do we tap into what we have through HSS and what are the other community resources for our families and our peer groups? I think that's critical to really developing that well-being and having those supports that are needed for that in the long term. How do we connect that to our families and our children and our peers and our community? How do we do that in a way, and what are the limits, and how do we plan strategically for that?
Hello, everyone. Good afternoon. My name is Rosie Ortiz. I work at HSA. I'm actually acting manager of the Learning and Organizational Development team, and I'm new to the well-being space. I was asked to lead our wellness team at HSA just this last fall. Of course, we were looking to start small and kind of um, reignite well-being resources and programs and interest at the agency. And then, of course, the telecommuting expansion was extended, right? Took us through January, then February, and then March. And so being new to this space, I echo what a lot of you have said, just, in conversations with the workforce. We have a lot of client-facing staff, some who have remained client-facing the entire time, many who were deployed as DSWs and are just now coming back a couple months ago. And we're transitioning into being in the office a lot more and into having, reintroducing our staff back into these client-facing spaces. And it is creating a lot of anxiety, increased leaves, increased workers' comp, and all the things that you all have echoed. And as a new person to this space, I'm excited to be here and to really learn from you. And I'm looking to figure out how to get started, right? It almost feels like overwhelming. Like, what do I try to tackle first? Like, what kind of resources are the most important to get in front of our staff now? And so I'm, excited to be here and to learn from all of you.
This on? Okay, thanks. Hi, everyone. My name is Judy Choi, and I'm with Animal Care and Control. And I'm part of the well-being team. What I'm seeing is that when the pandemic happened, I'm actually seeing the opposite. We all went to work. We all stayed at work, and the employees at work was like my family. Who I saw every day when I went to work. We were all very careful. We were all very concerned about COVID, but we all had a job to do, and that was protecting and taking care of the animals. And we had to scramble for ourselves with the animals. There were no other resources because we're the only agency for San Francisco. So we had to scramble to foster all the animals that are currently in the building with our foster parents. And then we were also assisting the city with animals that were being found, stray, injured, sick, people who couldn't keep their animals. So I felt like we never stopped, during this time. And even today, we did close, to the public, but we were servicing the public as well. So we were going by appointments, and we never went by appointments. It was just kind of walk in. So that was kind of new to us, as employees. But and then also we moved to a new building last year, and so we had support in a really smooth transition to our new building. And then we were still not open to the public yet. But we were still helping those that have lost their pets, needed their pets being taken care of by us, due to situations, that they were in. And we also had, our main challenges was helping those with mental illness coming for us for help. That's our biggest challenge during this time, and it still is today. And we feel that as a shelter office supervisor, we feel like at times that we are mental health providers, and we're there not to take away their pets. We're there to give them back their pets, but sometimes they make it very difficult to work with them. But we offer our staff physical activities. We took one of the training rooms, the biggest one, and made it into a workout room where we hop online and take the classes. So we've done the Zumba, we've done, the boot camp, and then I was also able to get a grant for an electric bike. And so our staff was using the electric bike to go out and just get some fresh air. So by being with the HSS Wellbeing, I'm able to, help, guide, our employees into through that part. If they wanted to go for a walk, if they wanted to go for a run, let's all do it. But I think that because we never stopped working, and I found it that we were opposite in terms of we were not isolated, that we had each other for support.
Hi, everybody. So I'm Carrie Bashirs, the Wellbeing Manager with HSS. I know all of you. So I probably come with a little bit different landscape, and honestly, it's no different than what you're all saying because it's very similar across the board because we serve all departments and all of our members. And what's been really interesting is you have I don't want to call it a divide, but what you do see is you have your essential everyday going to work never stopped, right? Which is a lot of the work that your departments, excuse me, have been doing. And then you have those that were able to work in a telecommute environment. But the things that I'm seeing, which you've already said, so I'm just reiterating it, is burnout, right? Exhaustion, whether you've been doing this day one, you've never stopped going to work, you've been DSW activated for many years. And then the mental health issues, which are, typically anxiety or concerns about safety. And, naturally we run the EAP program. We have been able to do a few things to step up in COVID to help with the need. And we know with what our presenters have provided us today, it's still not enough. But I know what my team is telling me, particularly EAP, is not only are we seeing an increase, but we're seeing an increase in the severity of people taking too long to get access to care, right? It's like I'm now here when I should have probably done some preventative care in advance. And then there's a lot of complex cases. So what we consider a complex case is really where you're talking about not just mental health, but there's the physical health that's combined to it. So they might be going to a physician where maybe they need mental health services, but they're not easily aligned with those. And so similarly, there are some common themes from a health perspective. I'm actually, if you don't mind, I'm going to transition to one of the questions, which really talks about, I think it's who do you leverage? Kind of who are your people that you leverage? So we manage a champion network of probably just over 200 employees. Obviously, a couple of you are either a champion or a lead or possibly both. And we really rely on our champion network to help us spread the message because there's a lot of employees. There's 45,000 employees. And like I like to quote Abby a lot, it's like when you've seen one department in the city, you've seen one department in the city, right? So there might be some similarities in that, obviously first responders and things like that. There are still a lot of differences among the type of work, your employees, the shifts, what they do, et cetera. And so our champions have been great, but we have had a lot of challenges with our champions because of what's been happening in the pandemic. Many have been called for DSW work, which is amazing, right? I mean, it's amazing to be able to provide that service, but they've stepped out of their roles. We've seen less engagement, and we've even seen it at higher levels because naturally you're there to call to do the work, and we're fortunate to have a champion network, but it is a volunteer position. So naturally you're kind of fighting with, I'm here to do my job and then I have to do my champion role. So we really do leverage our champions, and within the last 6 months, we have seen an uptick in some departments really engaging and stepping and engaging more. And we've seen some just kind of really deep and trying to kind of shovel, how do we shovel them out? How do we re-engage them? Like what you were saying, Tony. How do we get them back on board? How can we be there to help support? And then aside from us, obviously we have a lot of communication avenues, being the department that administers benefits. We send out a Better Everyday newsletter. We'd love to get more people reading the information. Our internal team has really come together to look at how we look at our e-news, our Better Everyday newsletter, what's presented to even our own staff and our board collectively, and kind of come up with a plan. So we kind of have these targets that we're aiming for to engage, hopefully engage people so they're utilizing their benefits more. But that's just one avenue, and we know it doesn't reach everybody. So
one of the things that we found, going back to the one of the initial presentations about leadership, really makes a big difference. We just got really lucky in the police department. They actually gave me more staff during the pandemic, to address these issues and to really get out in front of our staff on a daily basis. Because we were going 6 days a week with the pandemic, 7 days a week with the civil unrest in our unit, and let alone the officers getting held over. And so I think one of the things, NYPD hosted a forum right in the middle of the civil unrest, and we went to it. They had about 40 EAPs from across the country, and you had like Little Rock, LA, Dallas, Portland, and we went to learn, and we spent the whole time answering questions. What does San Francisco do? What does San Francisco do? And they were amazed at the partnership that we have with HSS, because they're like, how did you get that app? Well, we partnered with HSS. How did you do that? And I think we are ahead of the curve, but still there's room to grow, and I think for us, what we heard there was resiliency. That was the theme that was just coming over and over again. And so we've been doing resiliency with our recruits before they start the academy for 2 days, bring in a clinician in, talking about stress management, team building, where the resources are, and ultimately suicide prevention. Anything we do in our unit, the ultimate goal is suicide prevention. And even with that, we had a recruit commit suicide the summer before last. And, for us, we decided to bring it out to the stations. And part of resiliency is to talk about physical resiliency and talk about, primary care, go see your doctor. Have you seen your doctor, and all these kinds of issues. But I think, having a peer support team of 300 officers, NYPD has 300 peer support. NYPD has 55,000 officers, we have 300 peer support. So we're trying to I think the one-on-one interpersonal is so important, going back to, once again, one of those previous presentations about peer support, really, engaging the champions and getting out physically in front of people and talking to them is a big part of it for us.
Yeah, I'm curious. I'm curious to ask the other people in the fishbowl here, how you got staff during the pandemic. Do you feel like you're well staffed for what you're trying to do? Anyone else feel well staffed?
No.
Education at that level,
Yeah.
We actually lost staff. So we actually lost staff. We had a health and safety department, which was very small. So we had a 6138, which I think is an industrial hygienist.
Right.
We lost that person, and then the manager to that department retired. And so we've yet to fill that role, and we had to redistribute. And so it has been.
Good luck filling.
Right.
We tried it. We tried it. It was a no-go. But so that's also been challenging, because sort of like what you mentioned, Carrie, like it's important to me. And I know that there's a lot of people at my agency that consider it a priority, but I'm one person, right? And I also have another role. And so that's been my challenge, and kind of leaning on this discussion question, like what levers do you rely on to boost health access and engagement? I'd like to know what you all do, or what you did in the beginning to kind of get the ball rolling, because HSA has been in the partnership with HSS for some years now. Obviously during the pandemic, some of the like fun stuff that we were doing, we didn't continue with. But the other challenge that I have is that our agency is about 2,500 employees total, well, 23-ish, but we're really made up of like 3 large departments. So it's the benefits group, the Department of Aging Adult Services, and OECE currently. And so DOS does a really good job. They have a smaller champion team, but they're awesome. So that's kind of what I'm relying on. They're my model, right? So we do try to partner with them, but it also doesn't help that HSA has like 14 buildings or something funny throughout the city, right? And so the fact that we're located in different places makes it hard for one person to try to like coordinate everything and wrangle everything. So I'm interested in how you got started.
Well, one thing I did when I came in was just start a newsletter. There hadn't been a newsletter out of the physician's office, and it was obvious because the pandemic was bearing down on us. This was pre-vaccine. There was so much fear about what the virus meant, and so I immediately started a newsletter, hired somebody to make me a logo, and just put it out weekly at the beginning. Now it's every other month or so, but that helped a lot. And I just highlighted, we had all the telephone numbers of different people you could call for things, health and safety, the EAP, workers' compensation. We had all the resources available to people in a column on one side. And we always tried to highlight somebody within the department who was coping well or doing well, or what their thoughts were about the pandemic and how they were keeping themselves safe. You know, pictures of people gardening, or pictures of people with their pets, to try and create a lighter atmosphere in the newsletter, because the beginning always had the COVID numbers and the that did help. But back to staffing, I think that the old saying on the airplane of, put your mask on first, or in emergency medicine, we used to say, check your own pulse first. My pulse isn't so great right now. And we had a longtime administrative assistant who retired during the pandemic, and we have not filled her spot. So, we're all answering the phones. We're all making copies. We're all going to get the mail. We're all, sending the urine drug screens to FedEx and walking them over. We're doing everything. And that's been really hard, because I see the bigger need for me as the physician brought in to, run a program at the department. And, I'm having to file a lot, so that's tough.
I think staffing is something that we are all facing as a challenge right now. I'm coming back from the pandemic and just taking a look at the landscape of DPH. I mean, we're over 10,000 employees, and we're all over. So that not being co-located is challenging, but it's always been the nature of our work, because we have our hospitals, our clinics, our different sections are dispersed throughout the city. And so for me, just taking a look at, what we built with Carrie and the team with our champion program, and we're starting all over again, because it's like we're coming back to a new landscape. And so we recognize the importance of this, and we recognize being in it and living it and doing our work in it. We recognize the importance of the mental health, the physical health, all of this. And we know the partnership that we have with you is so critical, and we just need the time. I haven't had time to contact you. I mean, you've emailed me how many times, but it's just, there's, like you say, I'm the only one. I mean, in terms of how do we just get a baseline and triage our current state. And I think but we're committed to, because we realize, Carrie, that we need HSS. We need to reconnect and really do some strategic planning about how do we reconnect our workforce to the existing resources that we do have that we're not tapping into. And I think about, like, myself. I haven't been to the doctor in 2.5 years myself, and I am an absolute exactly. But it's like I've been deployed the whole time. I'm tired. It's like, but I'm like, I need to get back into that.
Yeah, you
And
do.
I do. And so I haven't done it. And so it's like, so whatever, it's like that kind of support, Carrie, like for everybody in DPH, all 12,000 of us. You're going to help us all get back to our, just reconnecting. I mean, just what is it going to help us to do something as simple as that is like so momentous right now to even think about doing that. So it's just those kinds of practical strategies of how do we really think about some basics. How do we go back to basics? How do we just, and we all recognize, with mental health and what's happening with our workforce and being so close to everything that's been happening and what that has done to the individual and to our peer groups and our families, that we need to be very careful and thoughtful about how do we have a strategic, response for that. That's going to help us with our well-being, because workforce is just depleted. And so how do we really get some reinforcements back in there? And it's really, great to hear that you got staff, and we're like, that is just, how did you do that? Because part of what we're looking at just getting back is like, how do we even work with our HR? And it's just the delays and all the things that we have going on in the city. Like, how do we get staffed up to be able to have just manageable kind of workloads? And something that's not overwhelming to everybody. So I think it's just having those conversations. I think we can get there. I'm confident that we can, but it's just a matter of having the time. How do we manage the time to do that work that's so critical? And I have an appointment. Just one of those, it's like I haven't done it, and it's like it's so funny because I go for everything. It's just like, but I haven't been. And so just that kind of
I mean,
reconnection.
we're asking our employees, the people we're responsible for, to engage in self-care, and we're putting out all that messaging, and when you look at the people who are, in charge of health and safety and health not caring for themselves, that you have to start with us. Yeah.
Okay, well, I think some of the things that this may take a little while to get going. Is that not? I see it just doesn't like me. Okay. What couple of things that we did just quickly is we have a 24/7 nurse triage hotline that is available to all employees in the city, and so that they can report injuries. We expanded that function to be able to provide information on COVID prevention, exposure, if you were sick, and just a lot of information. So that's one thing that we did. We've been partnering with HSS and Carrie's group and EAP and ART as well to try and see if we can get a bridge to workers' compensation if someone gets to the point where they actually have to stop work and file a stress claim, that we can have a bridge that EAP can continue to support that individual until I can find a practitioner who will agree to see them. Because there's a shortage, again, as I say, in the Bay Area. Again, leveraging telemedicine, which has been very successful for mental health care. We've been able to now expand our network of providers using telemedicine. So those are some of the things that we've done.
Yeah, I just wanted to add a little bit into kind of how do we get back to where we were. And I like to say, I'll just, leave my well-being Kool-Aid and give it all to you, and y'all can drink it and give it to everybody else. It's not that easy, right? And I think that that's what we're starting to see, people that they want it. So but how do I start? And I think it is really going to be a conversation, because it could be like, how do we re-engage more people? Because I get you're in large organizations and your bandwidth is very narrow. And we are here to support you. And so I would say in my perfect world, it's a culture, right? So it's everywhere. So it's not just you leading that. It comes at every level, but that takes time, right? And, I've been with the city doing the well-being work for just about 8 years. And I would say, most people say, oh, it's really established. And it is, but it has a lot of growth and ability. And so I see like how we can collaborate is to continue to partner. We've built a lot of partnerships in COVID. It's amazingly, as much as it moved people apart physically, it's brought a lot of us together to work together. And there's been a lot of bonuses and positives to that are going to continue on as we grow the work for mental health and well-being for our workforce. Absolutely. And that's where we're here to help support you and then help to brainstorm, like, how can we actually kind of get back to this space, and what does it look like? Because it's going to be different, right? We still have people in a hybrid setting. Virtual is not going away. If anything, it's going to continue and be even more enhanced. So it's expanding the opportunity and hopefully our outreach to how we can get to all of our employees, or we call them members, in different kind of avenues throughout that. But, and I appreciate that there's really still the want and the drive, because this is the time where people, well-being is not going anywhere, but people are really saying, wow, this is something I really do need. And, when I was talking to Derek, who did the presentation earlier, he kind of mentioned it today, is when it comes to mental health, there is really no push for preventive care. You know, it's like, I'm here, I'm at the top, I need to go see somebody, or, oh, I've got to go do something now. And granted, we want to get our preventive care numbers up too in general. And thank you for getting your doctor's appointment, because you'll help with that number. But a lot of it is preventive. You know, what can we do, as Dr. Brokaw, you were saying, with the PTSD and stress claims? How do we kind of nip that in the butt? And that is hopefully the goal, that we're all here to have the conversation and say, how can we kind of move that needle, even if it's going to be slower. So,
I think too, if I could just add, and something that Dr. Brokaw brought up is, I think, we're still seeing just a lot of anger, right, from employees and about the vaccine mandate, being told that they had to do that as a condition of employment, which, I personally felt was an absolutely right thing to do, but a lot of people didn't. And I think there's still a lot of lingering resentment about that is probably affecting people's engagement with their work. Right? I mean,
Yeah, absolutely. Absolutely. Yeah, the fallout from the vaccine mandate was really unexpected to me. How long I thought it would be, they'd be over it by now. But even people who complied, that did so reluctantly, are resentful and are very aligned mentally and emotionally with those who actually lost their jobs. And boy, undoing that is going to be really tough.
We held debriefs for the vaccine mandates, the folks that didn't want to get the vaccine. And one of the interesting things, we separated these folks in terms of the ones that weren't going to get it, and then we had the ones that got it reluctantly, and they had a much harder time. The ones that didn't get it, they had sort of united, and they were in their conviction. The ones that got it reluctantly really felt violated. I mean, it's the best description, and it was very hard. And I was honestly worried about a suicide around this issue. We were getting calls in the middle of the night from folks around this, and it was getting really scary there for a minute. And so, knock on wood, we seem to be past this, but it's just these times have been, really tough. And so, in terms of, I can't stress enough, upper management supporting wellness is so important. And it was mentioned earlier, if upper management is on board and willing to commit some resources, then there's a chance.
Yeah, I just wanted to jump on that with management being on your side and caring about their employees really makes a difference, because they listen to the staff, and then you can see how they're working to give us what we want and what we need, and then providing that help and getting that help for us. And yeah, sure, we lost a few people during the pandemic, because they moved on to other jobs. And it wasn't because of burnout or anything. But I can say that I have 2 openings, and we're in the interview process. And so I'm lucky enough where the director fought with HR every week saying we need to fill these positions, and I don't know how she did it, but I got my 2 positions open. And so I'm almost like ready to hire 2 new people. I have 3 candidates that are in the running. And then we have our other departments that also need staffing. And she's also fighting to get those positions filled, even if it's a temporary position and not a full-time. So every little step that they're doing really helps with the morale and the support that the staffing needs. And I mean, we're a small department of 60 folks, but we're all there, for the animals. So all I have to say is everybody needs a pet. Okay, you just need a pet. I mean, I have a office hamster, which is our emotional support hamster. Everybody comes in and says hi to her, and that's what you kind of need. Maybe you might need a fish in your office or something, but it really does brighten the day.
yeah, I was just actually thinking about that, because I think I mentioned culture. It's a big piece of it. And I think as leaders, it's challenging to practice your own self-care. And that's where I have seen success, is where the leader says, I'm going to do this with you. I'm going to actually say, let's stop right now, and together we're going to do this. And that makes people feel like it's okay because my boss is the one telling me to do this, and they're doing it with me. And it is challenging because sometimes it's like, it's all about the work. It's the work, it's the work, it's the work. And oh yeah, I'll do that when I go home. And then you're exhausted and you go to bed and wake up and do the next thing. And so I think that's where you see successes in departments like Judy's, is that it's really at all levels, and as difficult that it can be, but to really like chalk out that time to do it with your team, to take and allow space to say, are you okay? How are you doing? Do you need to step out? Do you need to step out together? Do you need to go like grab coffee with a buddy? What do you need to do? Because it's work and it'll be there tomorrow, right? But it's hard to say that because it's a lot of work. So I think that's a lot where we have seen successes. And, granted, for I think larger departments where there's a lot of bigger structures, multiple locations and buildings, you kind of have to chip at it a little bit differently. But I do think for us, kind of leveraging and increasing engagement, it's like they say, it takes a village to raise a child. It's the same, definitely the same in this case. So I'll be calling all you when we leave here. That's okay.
I have the opportunity to talk to a lot of outside agencies in the Bay Area, around the country, around the world, have come through to see our unit over the years. And I can't tell you how many times you'll get middle management, the union, everybody buys into this stuff, but upper management doesn't, and how all these programs will die. And really that is so important. Chief Scott, one of his first things when he came in, it was, how do we take care of the officers? And I don't ask for much, but when I do ask, he says yes, and it really is that kind of support. So I just, whatever education, this conversation should be held with, our bosses, basically.
I think we're getting ready to wrap up the activity, or else we'll serve dinner and we'll be here at this fireside chat all night. All right. Been taking vigorous notes. I think there's one thing that's a startling reality, is that narrative matters. Right? Narrative matters when it comes to imagining the future state of our benefits and programs. And as we close out, just wanted to open up the floor in looking at the observation questions on the handout, wanting to invite a few members of the observer group in the audience, if anyone has any information they'd like to chime in, any reflections, similarities, differences in points of view, key takeaways. What was it like to listen on the outside of that narrative? We have behind.
Thanks.
Hi, Denise Rodriguez from Kaiser Permanente. What really struck me throughout the day is mental health is such an issue, and it's not just a San Francisco issue, it's a national issue. And every single one of you talked about burnout, about mental health issues, and how do we solve it. And I'm encouraged to see everybody coming together with the same narrative, trying to achieve the same goal, knowing that we have some challenges. So big job ahead, but I think with all these smart people in the room, we can see some change.
I'm quite impressed with the conversation, and I guess as a physician, one of the things that really struck me, and I have a question for you all, was the reaction to the vaccine mandate something that you could have predicted? Because there will be other mandates in the future, and I think as we as trying to help provide, sort of encourage HSS to be proactive. And this came up over and over again in your themes, was what can we do to help anticipate the next stress? The vaccine mandate was, I'm impressed with how strong the reactions were. And again, I ask, Could that have been predicted in your own departments or workforce or peer groups? And what can we do to maybe think about how to predict that for the future and the next mandates as we move forward?
Oh, did you have something to say? I think the one thing that was helpful during the vaccine mandate period was giving the employees some choice. And so I became a vaccine site at my office, which I don't know if I would do that again, because then I think I ended up being seen as, putting the needle in the arm and, the enemy. But I did offer people choice of vaccine. So I made sure to have J&J and an mRNA vaccine so that, I'd say, which one would you like? And, this is what I recommend, but I'll do whatever you want. And that did help. And then when the booster came around, even though J&J wasn't really a recommended booster, if you had a J&J, the recommendation was to get an mRNA. I boosted several people with J&J again. They were just really dead set against mRNA, and I didn't push back at them at all about it. Well, there wasn't, needle phobia was underestimated as a reason for vaccine hesitancy, I think. And I think in the future, there will be more choices for vaccine against COVID. Lots more vaccine, and that will help. That will help a lot. And maybe there will be some nasal vaccine and stuff like that. So it's going to get better, but you don't think so, Peggy?
I think it's cultural. There's a big divide, right, about vaccines. There's a large, portion of our American population that is anti-vax, period. And so a portion of those people work for the city. And you're never gonna, I don't think in this kind of setting, I'm not sure you're ever gonna, you can predict it maybe. Then the question is, do you backtrack, or do you move forward with what we believed was the strong public health, correct thing to do to protect the health of our employees and the public? So my thoughts.
I think that a lot of it is cultural. But I also think just the fact that it was a mandate, it wasn't a choice, right? And the fact that, so you're asking if we anticipated that reaction from our workforce. I think just by the fact that they had to, that it wasn't a choice, that I could already see how it was going to play out with the friction, right? And then just like from a personal experience with my family, like I think it was a lot of misinformation, right? My mom is from a different generation, gets her news from unreliable sources, and then her network is, her siblings who get their news from the same place. And so kind of, I think a way of preventing that to happen again is really to try to inform people, but consider that cultural aspect, because it is important.
For us, it was really trying to support people, whatever decision they made, just so that, once again, suicide prevention, but, and educating them as much as we could. That's why we would do these informationals and debriefs, and just some people, they needed that extra information. Some people weren't going to change their mind, but supporting them and engaging them through the whole process and afterwards too, and if somebody had some hope, like, okay, I'll get a job somewhere else, I was grateful. But if they had no hope and they're like, what am I going to do? A single income mortgage, little kids, then we're getting a little nervous, and so, but, and a drinking problem. And then they were really nervous, so, but yeah, I don't know how to predict it, the reaction. It's tough.
I think it's important that whenever possible, people culture is real and history is real. And you can't deny that. So I think going forward, just recognizing that and the reality of that history and culture. And I think when you start the conversation that way, it gives people an opportunity to be involved and to feel that at least they were part of the discussion. And then, whenever possible, coming up with options and choices, and just realizing that, we live in a world where, choice is critical in terms of how, because so much of what has happened is so many, when you think about inequities and oppression, that the choice wasn't there. And so I think it's hard to get in front of it. I mean, because you just don't know. I mean, we're still in the middle of COVID, guys. I mean, we don't know we're still learning. And so when you have such unknown, like, the only real response that can, is the respect of people and communities and culture and history. And if we can bring in that kind of a context and frame it that way, even if, people are unhappy, they will remember truth and respect. And you don't like the outcome because we still may be exactly in the same place. But they will remember that there was, an honoring of history and truth and conversation about that and choice. And feeling heard, because if you think about, that's just the important piece of respecting humanity, in terms of how many times we were not heard and we were not asked, and we didn't have a chance to participate in whatever the process was. And so you may not like the outcome because, you can't please everybody all the time, but if you had a chance to honestly and authentically participate in the process, and however we can frame our the situation to be that kind of a stature, I think you're going to be in a better place.
So I think that this vaccine conversation, that really reinforces my observations about being an observer of this process, that you started out just kind of answering the question, but then it evolved into a conversation because you all had, separate and distinct experiences, but yet you saw similarities in the other experiences, and that was really powerful.
One of the things I wanted to just comment, again, I was quite moved, Judy, by your comment about animal control, because it seemed clear to me that your department, could unify around a mission. So as much as all the other issues may impact individuals in a different way, you are unified around a mission. And I guess the question I have for all of us is, what can HSS do? What can the Health Service Board do to help us come back and focus on the mission that each of us must feel in our own departments? Everyone in this room is wearing a mask. We all agree on part of our mission, I think, not only to ourselves, but to everyone around us. So how can we further that? Because that was a very powerful message to me, and I heard it in other comments as well, that maybe we need to improve on that.
Well, as we do wrap up, understanding that we have the forms as well, I don't want to lose any of those critical thoughts you might be having, whether you want to bring them forward or not. If you are able to provide some input on that takeaway form for us, contextualizing some of the questions that we've heard from the audience, just wanting to run home some of the themes. Trust, this building of authenticity. It was very clear in the context of this conversation, and that this dialogue and observation style inspires that. So I just wanted to afford a little bit of appreciation and gratitude for our conversationalists. Also, we heard this ideology of critical strategic planning. To our president's point, how can we bring this back and implement it in strategy, right, to move forward the mission, vision, and values? And it's conversations like this that provide the qualitative, that complements a lot of the quantitative that we're often steeped in. We've heard the resonating tones of physical and mental toll, engaging or reconnecting to our workforces on accessing primary care, not only for themselves, but for their loved ones in a timely way. And we've also talked about sphere of influence. How can we continue to collaborate, not only to move the needle in the city, but to create policy change on a broader level with the understanding that San Francisco is viewed as a model? So I ask to all the conversationalists, you're the eyes and ears of your department when it comes to the health and well-being of your workforce. And I ask that the audience please join me in showing them some appreciation.
Yeah, that was super. Thank you so much. So little experiment we put together, but I think it worked really well because we had such knowledgeable participants. I'm trying to, where's the clicker? I have no idea what order I'm in here. That's 15. I'm going to back up to. So thank you. I just want to give you a couple little snippets since we did have a preview of the slides from the presentations earlier today. I wanted to kind of give the board a framework for how we're considering some of what we learned here. And so on the conversation that we had, or the presentation on mental health, you know, we did talk about what we've put up here is sort of currently what we have. We do have sort of a no wrong door philosophy. There are many ways in for our members to get mental health services. And we're working on some graphic tools and other things to help all of us understand the many services that are readily available today. We're also, continuing to look at that question of evidence-based. I think you raised that up and we discussed it earlier, Dr. Follansby, and then really looking at the shared goals and metrics across all of our carriers. Obviously, I didn't do a really great job of prepping our two presenters on all of our plans, so my apologies if we overlooked or overstated. I also had no idea Kevin Grumbach was on the board of Canopy Care until today. So that was an oversight on my part. But I think we're all kind of one big family here. We all know who each other is, and we really want to align and move this together. And we've had lots of robust conversations about standardizing measurements so that we can be sure that we're aligned. And if nothing, and then I'm jumping into Kevin's presentation here. So then we have the future where we really look at clear pathways to help people get the right care at the right time. The whole concept of preventive mental health is a really cool concept. Looking at the problem that we all know of the lack of diversity amongst the providers that we have, and continuing to look at that. And I think all of the providers everywhere are trying to figure out this integrated behavioral health model. There's many different ones that are in play, and I think we're all learning a lot. So on the primary care presentation, again, we did standardize a lot of our metrics. All of our providers do participate in the IHA, the Integrated Healthcare Association improvement targets. We've got really strong ACO partnerships through Blue Cross. Kaiser's can teach all of us about team-based model and what they've learned that works, what they've learned that doesn't work. I think it's really helpful to the industry as a whole. We've got our new partnership with HealthNet Canopy Care, and we have developed more direct conversations both through the ACO with Blue Shield and directly with our IPAs themselves to bring home the message loud and clear that we really do want to pay for value, and that looking at this impact of the primary care cost and its investment in reducing the total cost of care if done well. So as we are looking at how we can continue to rebalance that work within the cap, because we do have primarily HMOs and the payments are capitated, but so how can we influence that and refine or broaden any of the outcomes-based measurements that we all are rather elusive to all of us. And I think that's an area that industry-wide we would all like to see better outcomes measurements to be even on the table, let alone investigated and reported. So this is an example of how we're thinking about using the information that was presented here today for the development of our strategy and goals for the next several years. And so what I'd like to do next is just kind of ask Anne to just give us a few takeaways that she's heard as a primary note taker here today and listener on all of these conversations. And then, time permitting, we'll have just a short session on the reflection question, which is, what did we learn and what else do we want to know about these particular topics? I'm not opening it up to the whole whole universe here, but on these particular topics of mental health, primary care, and workplace health. So those would be the three topics that we'll talk about. But first, we'll let Ann kind of highlight the takeaways from what we've heard thus far that perhaps I haven't already stated. Okay?
Yeah, thank you. Is this thing on? Sorry. Okay, perfect. All right, so my key themes, heard kind of a lot about flexibility, recognizing, if you've seen one department, you've seen one department, and really understanding where people are and meeting them where that might be. Heard a lot about going upstream and the idea of the preventive care around wellness or preventive care on mental health. And then, of course, wellness is in there. Peggy spoke to that, especially within the workers' comp arena. And then that we are seeing more kind of utilization of workers' comp of the disability benefits and that things are more severe. So we really do need to go to that upstream perspective to be proactive versus reactive. The partnerships with other departments really came out clear, I think, in the conversation, and I think we know that we've known that, and this really validated that, and that was really wonderful, and that we really do need to lean on each other to make the changes happen, to provide the wellness to keep the conversations going. Tony talked about reconnecting with the workforce, that we really need each other. We need to engage. If people are not engaged in programs in their health, we're not going to see, improvements there. Understanding the spectrum of care. And really, I was thinking of, when I wrote that, I was thinking about mental health specifically, and that there is a spectrum of care that people need and that could change. So people are dynamic. But really thinking also about care. We didn't talk today about copays or deductibles or, networks. And a little bit about networks, I guess. But, we talked about care, peer support. The app that, it's a fire that mentioned, or police mentioned the new, the Cortico app that they have for mental health. And so really thinking about how do we provide care and support of each other outside of the physician office necessarily, right? I mean, there's a whole spectrum of care, going back to basics with primary care. And then really just that, leadership, the culture of wellness. We have a really strong foundation. Let's continue to build on that. And the caring and listening, which we heard here at the end with President Follansby's question around the vaccine mandate and how do we, prepare for whatever is the next mandate. And really a key part of that was kind of that listening. So that is what I captured. If anyone would like to disagree or add to.
Oops. Mike?
Thank you. I think your presentation is excellent. I'd like to add communication and education, because I think we still have a long way to go to communicate to 150,000 employees that we have in the city and retirees, and also education about primary care and health. We are unique in the fact that we have a really good health benefits system. And when I see other organizations and realize that they really don't have access to decent health care benefits, and in many cases they're paying lots of money for very little benefit, we are really, really fortunate. But I think we need to help communicate with our colleagues about what they have and how to get the best bang for their buck is probably what it boils down to, and how to best utilize the system, and that we focus them back on primary care and let them understand how they can use this system and get the best care. And educate them to maybe what the next pandemic will be. We don't know, or what the value of vaccines are, or somehow we also need to address the various, we have an incredibly diverse workforce, and we need to be able to address what I was hearing is that depending on your information source, depends on your misinformation, your lack of information, or basically what you consider your best information. And it may or may not be the best, it may or may not be the most accurate, but we need to be sensitive to that. So that's why I'm adding education and communication to all the collaboration. Thank you.
Thank you. So let me just open it up, I think to the sort of reflecting on the whole day, not just the last panel, but what have we learned? What else do we need to know?
I mean, I'm never short of words, I guess. Can you hear me all? I mean, number one, I came away from both the last session, also earlier, that we need to champion our champions. The term these days, I think, out there in the media are influencers. And it's a concept I don't understand. How someone could make, $200,000 off of their YouTube influencer role. But we need to, I think, champion our champions and encourage them. I've heard a lot of stress, even among the panelists, over the challenges they face. And if they're stressed and not getting health care, how do we expect the rest of our members to tap into this? I would like to see HSS focusing, and the board focusing on our champions, and expanding that program that we need to do, reinforcing it department by department. That is what I came away from. I think a concrete thing that's come up in some of our board meetings is that we get these figures about how many primary care providers there are in various health plans and where they are geographically based on either their home address or their work address. You get this regarding dental plans, you get it around, optical plans and all that. But I'm not quite sure that we can trust that data. I've heard a lot of concern about where these people are. And I know that there were moves in the health plans to actually expand the access to primary care. I got a message that the Kaiser member that Kaiser was opening up urgent care, but not primary care, down, I think, at the Transbay building or something. And that's not primary care. That is different. But we need to know what each plan is doing to enhance not only the number, but the diversity of the primary care practice. And I'd like to see us move away from the primary care doctor. I'm a doctor, so shoot me. But really what we heard is the primary care approach to healthcare delivery, which includes a lot of mental health and vaccine support and cancer screening, et cetera, et cetera. So we need to rethink some of the words that we use, the way we outreach to our members too, so that expectations of what we want them to access, that's the reality of what our health plans are providing, and not necessarily 24/7 phone call access to your doctor.
Don't all speak at once.
Thank you. Great. The thing that I come away with is that I've had a wide review of information, and now the question is, how do we take it to the next step for setting multiple year goals and objectives for us to kind of settle in on. I was particularly impressed too with the fishbowl conversation, that it reinforces once more that we have a great number of dedicated staff and leaders in our city government that work hard every day. And that came through very clearly, that out of all of the stress and concern and so forth that was expressed, they were also trying to figure out how they were going to continue to serve the citizenry of this city in a very fundamental way. And I think that that has not been recognized enough with all of the other overlay of issues that we have here, that we have people in the trenches day in and day out worried about how they're going to serve us, the public. And I think we should be rather proud of that. But I'm waiting for the next step for us as a board.
Well, you teed me up. Let me move ahead here. And the key takeaways. Next steps. I love it when a plan comes together. Yeah, so the next steps is we're gonna take all this home and develop an internal process to really look at, really consider what we learned here today to determine what those strategic goals might be. And then what we need to do is some hard work and analysis on comparing current state. And as you recall, at the last board meeting, we reviewed all the, or a sampling of all the information we have about the current state. So that is going to be the work that we have to do, is kind of look at where we're at and where we think we need to be around primary care, mental health, and workforce issues is what we covered today. We will be, because we did not, when we designed this workshop, we ran out of time. So we decided that our June board meeting, we expect our Medicare plans, you'll be very happy with how they're gonna, set the rates this year. So we won't spend a lot of time proving those. And that we will be able to have another education session at the board around retiree health. Similar to what we did here today. We haven't designed it yet, but we know that talking with our retirees is really important, whether we do it during the board meeting or separately. Get over by the mic. Yeah, everybody did this today. We're going to buy the library some lapel mics. But anyway, we are going to design a little mini workshop for the June board meeting around retiree health, because it is a gap. And then there's some other educational issues that we need to take a look at, but quite frankly, when we think about strategic planning and what we can do, I think about it in three circles. There's the inner circle, which is what we can control. There's the next circle, which is what we can influence. And then there's the outer circle, of which we have neither influence or control. And unfortunately, I put pharmacy in the outer circle. It's interesting, but HSS, what we can do about the pharmacy and the specialty drugs and all of that, we follow it. We're talking our plans all the time, but I don't think that's going to be a strategic goal. And similarly, there's other technologies like genomics and things like that are interesting kind of future state things that we will educate ourselves about later in the year. But we're going to kind of stop the clock on the inputs at the June meeting. And then in August, present to the board our draft strategic goals. And then with the aim to approve the strategic plan in September. So does that work for you, board members? Okay. So I think that's a wrap, is it not? It's time for our public comment.
Yeah. So if there's no other comments or questions or issues, we'll go ahead. For every agenda item, open this up for public comment.
Mike, I think it's coming through now. All right, thank you, President Follansby. We'll move on to our public comment. Making sure our mic is working for our virtual attendees. So virtual public comment will be taken both in person and remotely via WebEx. In-person public comment will be first, and then people attending the meeting remotely will move to WebEx. For anyone waiting in person, you can approach the podium now, and you'll be called after the virtual public comment instructions have been read aloud. Each speaker will be allowed 3 minutes to comment in length unless the board president deems new public comment time limits during the meeting. All public comments are to be made concerning the agenda item that has been presented. As a reminder, a caller may ask questions of the policy body, but there's no obligation to answer or engage in dialogue with the caller. For those callers on the line, when I welcome you on the call, you're encouraged to state your name clearly, although you may remain anonymous. And I'll give a 30-second audible warning when your time is close to ending. When your 3 minutes have ended, I'll say, "Thank you, caller. Your time is up." You'll be placed back on mute, and the moderator will unmute the next caller. Remote viewing is available on our WebEx platform. Opportunities to speak during the public comment period are available by dialing the number on the screen. The dial-in number is 415-655-0001. Again, 415-655-0001. When prompted, use access code 2482-123-9217. Again, 2482-123-9217. Then press pound and pound again. You'll enter the meeting as an attendee on the public comment call line and dial *3 to be added to the public comment queue. When the system message says your line has been unmuted, this is your time to speak. For those already on hold, please continue to wait until the system indicates you have been unmuted. I'm looking around to see if anyone has approached the podium. No one has requested the public comment for in-person, so we'll move into our virtual public comment. We have 3 callers on the phone line. 0 callers have specifically entered the public comment queue at this time. A reminder to all callers on the line, you must dial *3 now if you want to join public comment for the specific agenda item. We'll wait 5 more seconds and then close public comment for this agenda item. There are still no callers in the public comment queue at this time. Hearing no callers, public comment is now closed.
Thank you very much. The meeting is now adjourned.
Meeting adjourned, 4:44 p.m.